how much radiation dose does it produce? 0.02, what is that? MSV. Anyone? MSV. What is the radiation dose? Physics se paro nahi? Sievert. Millisievert. Yeah, millisievert. Okay, so this is the one chest X-ray is 0.02 millisievert, but whereas in one abdominal X-ray is 0.7 millisievert. That means one abdominal X-ray is equivalent to almost. It's not working. এটা কোনো ভলিউম বাড়াতে আর দেখো তো কোথায় গেল এটা এবার আসছে so one abdominal X-ray is equivalent to 35 chest X-ray. See how much of radiation on one abdominal X-ray, and if you go for CT scan typically radiation dose is 9 to 10 millisievert. So one CT means almost 14 abdominal X-ray. So you can imagine how many chest X-rays. Why radiation dose is important? The radiation is good or bad for health? Up to a certain level is okay, because we have to diagnose pathology also. So up to certain level is okay, but beyond that level is harmful to the body. It may cause cancer, it may cause leukemia. So that's why we are concerned about radiation dose. Okay, যারা দেখবে ইয়েতে কাজ করে এক্স-রে ডিপার্টমেন্ট বা সিটিতে ওরা একটা পড়ে থাকে, একটা ব্যাচ পড়ে থাকে, ইটস বেসিক্যালি গাইগার মুলার কাউন্টার। সো কতটা রেডিয়েশন এক্সপোজ হচ্ছে তার উপর সেটা ওখানে দেওয়া থাকে। ইফ দে এক্সিড দে উইল হ্যাভ টু গো ফর আ লিভ দেন। ওকে, সো দে হ্যাভ আ ব্যাচ, কতটা লেখা থাকে টিএলডি আর কি, কতটা ডোজ হচ্ছে সেটা লেখা থাকে ওখানে আর কি, ওই কাউন্টারটা ক্যালকুলেট করে ওটা। ওকে, সো দিস ইজ দ্য রেডিয়েশন ডোজ। So we need X-rays, but it's not like that. We'll do whatever. Just do an X-ray. It's not like that. It's indicated, we'll do. If not indicated, you won't do, because the radiation dose is important. Okay. So now, both are abdominal X-rays. This is the right hand side. This is the left hand side. Okay. This is right hand. In X-ray, always see. The right will be this side. This is the right hand side of this X-ray. This is the left side of this X-ray. Okay. Always remember, in any X-ray, this will be the right hand side. This is the left hand side. Okay. So both are abdominal X-ray. Can you tell me which one is better? This one or this one? Right. This is the right hand side. This is the left hand side. Don't look at the pathology. Which one is better? এটার জন্য কারা কারা, আর এটার জন্য কারা কারা? So more on this thing, but democracy wins this time. Okay, why? Very important. So what constitutes a good abdominal X-ray? See, it always include the pubic symphysis. Ideally, the inferior rami also should come, but at least this one should come. See here, it's not there. Okay, so one good abdominal X-ray means you have to see the symphysis pubis. This is symphysis pubis, also the inferior pubic rami. It must include the diaphragms, both the diaphragms. Okay, and it should extend laterally sufficiently so that you can see the musculature and everything. Okay, so one good abdominal, don't talk please. One good abdominal X-ray means you should see the diaphragms, you should see the symphysis pubis, and also laterally sufficient breadth. Okay. Now, what are the things that we look for in abdominal X-ray? Can you tell me what are the indication of abdominal X-ray? Why you should do abdominal X-ray? Fine, if you suspect some renal calculi, sometimes definitely we do, number one. Okay, then mostly in acute scenario, we don't diagnose any chronic conditions with an X-ray. Mostly for an trauma, definitely trauma, some fractures, definitely some refracture, definitely trauma also, good. see, soft tissues and the organs, they are not very much well delineated in X-rays. So what are the emergencies for which we normally order X-ray? Trauma, bone fractures, yes, mentioned then. Abdominal particularly. Organomegaly, they see organ and soft tissues are not very, good for, X-ray is not a very good modality. Foreign body, definitely foreign body, very good, foreign body. Then, another two emergency indications for which X-ray is very routinely done. If you think there is perforation of intestine, perforation of intestine, you order an X-ray. Or if there is intestinal obstruction, just to prove it, you order X-ray. So, indication of abdominal X-ray, number one, mostly in emergency setting. Remember, emergency setting. Suspected perforation, number one. Number two, obstruction, intestinal obstruction. Number three, if in case of trauma, you can do. Number four, foreign body. Okay? Okay. And stone, definitely stones. Yeah, stone. First she mentioned. Yeah, stones, definitely stones. Kidney stone. Yeah. Suspected perforation, then obstruction, stone disease, foreign body, trauma, fracture. Okay. Now, কি দেখা যায় তাহলে একটা abdominal X-ray তে? This is a good one or bad one? Not so good. Hemidiaphragm is not there. Symphysis pubis is there, but the rami is not there. That was a better X-ray. But once you come in the clinical practice, you will see variety of exposures. Some will take this one, some will take that one. But that doesn't make a good X-ray. One good X-ray means we should see hemidiaphragms, we should see symphysis pubis, ideally the inferior rami of pubis also. So still, what you can make from this? What is this? Key rib. 12th rib. So that means this is T12. Okay. Now what is this? L1, L2, L3, L4, L5. What is this? What is this? Iliac. Then what is this? Sacroiliac joint. So you can see a faint black line, isn't it? Okay. This is femur. Head of the femur, acetabulum. Okay, so they are in the socket. This is the SI joint. Okay, what is this in vertebrae? So the spinous process. They are in midline. Spinous process. Okay, they are spinous process. In midline only. Okay, can you see one faint line like this? Both side. What is this? No. See, whitish. Gas will be black. Gas is black. One line like this, one line like this. Yes. Which muscle is this? Rectus is a straight muscle. Psoas muscle. This is psoas muscle. Think of the psoas origins. Okay, and anatomy. So this the psoas major, they give like a line like this. Okay. So this is otherwise okay. Vertebral column is centered. There are some bowel gaps you can see. Okay. Ribs are equidistant from this thing. That means there is no rotation. The film is taken in a good. The technicality of the film is okay because they are equidistant from the margins. Ribs. Okay. Psoas visible. Spinous process in the center. Okay. Sacroiliac joints are equidistant from these things. আমি যদি একটু বেঁকে ছবি তুলি এগুলো সব distorted হয়ে যাবে. So it should be straight for interpretation. Okay. Upper border symphysis pubis included. At least it has to come. Okay. So this constitutes a good film. Normally in a film, the first thing you should look for details of the patient, the demography. Okay, what is the patient's naam lekha thake. So any film you are asked to interpret, first see কোন পেশেন্টের মেল ফিমেল কি লেখা আছে ওখানে, ইউজুয়ালি ডেট লেখা থাকে আর ইউজুয়ালি রাইট আর লেফট লেখা থাকে। রাইট হলে এখানে আর লেখা থাকবে, লেফট হলে এখানে এল লেখা থাকবে। Because if it's a bilateral disease like a kidney stone, it can happen in right or left. If your side is not correct, your everything, the all interpretation will be wrong. Okay. So in any X-ray, the first thing to look for is these things, these writings. Is it the correct plate, correct patients, kobe tola, and kunta right, kunta left. That's the first thing you should see. Okay. Now, what are the abdominal X-ray projections? It's a AP. I mean, normally we write supine X-ray and erect X-ray. And sometimes, if you are very, from the symptoms, if you are very sure that it is likely a kidney stone, we ask just X-ray QB. Okay. So, normally, supine view and PA erect view. Supine view is AP. What is AP? Like this. Patient supine. So, the X-ray beam will come from anterior to posterior. So, this is AP view. Erect means, say, everyone has done chest X-ray, no, for medical clearance. Okay. So, the view will be some here. We'll stand like this. X will come from here, and here is the plate. So, that's a PA view. Okay. So, erect is usual an PA view, and supine is usual an AP view. And sometimes, when we are very sure that this is likely most likely on kidney stone, we are asked for an X-ray QB. Okay. Now, remember this mnemonics. What to look in abdominal X-ray? A, B, D, O, X. What is A? A for? Always A for like ABC of resuscitations. So, A is always here. Here also A is here, but B is different. B is bowel. D is for dense structures. So, what are the dense structures? Bones. If some calcifications, some stones, that will be also dense. Okay. Then O for organ, soft tissue, and E for any external object and artifacts. Yeah. Foreign bodies can come, then drains can come, stent can come. So, different types can come. Okay. So, one by one. So, how to interpret X-ray? First thing, demographic and date of the film and the side, correct side. Otherwise, in examination, in a right sided stone, if you say left side, what will get? Marks 0. Because you are wrong. All of you have heard about this thing, no? Sometimes the surgeon has opened the wrong side. You know, it's very common. Always flashed in the paper. These days it will flash everywhere. WhatsApp, Facebook, wrong side has been operated. Okay. So, date, demographics, date, and the side of the film. Very important. Never forget. Okay. Then A, B, D, O, X. A for air, any free air or not. Free air means, we call it pneumoperitoneum. That means some perforation. Then otherwise, go for B, bowel gas. Obstructions. Obstructions will have different patterns. By that we will determine intestinal obstruction is there or not. These are the two very common indications for ordering an abdominal X-ray in emergencies. Perforation, suspected perforation, and suspected intestinal obstruction. Okay. Then D, the dense structures, bones, calcifications, stones. Okay. And then the organs, different organs. I'll come. And the last thing, X, any foreign body, any devices, anything. And you have to summarize the notes. So, where should be the air? If I do an abdominal X-ray, where should be the air? The air should be, normally do you have free air? As before discussing it, what are the contraindication of X-ray? Anyone? Pregnancy, yes. Because they are radiation dose, no? So, in pregnant female, you cannot do abdominal X-ray for the safety of the baby. Okay? Because it will have bad effects on his skeleton and this thing. Okay. So, where should be the air? Air should be within the bowel lumen only. We don't have normal free air inside abdomen. Okay. Now, if you suspect some perforation, We call it pneumoperitoneum. If intestinal perforation occurs, be it in the stomach, কোথায় কোথায় perforation হতে পারে? Stomach হতে পারে, duodenum হতে পারে, duodenal perforation হতে পারে, intestine, small intestine হতে পারে, large bowel হতে পারে. It can happen anywhere. Wherever it occurs, some air will come, and you can see pneumoperitoneum. So it will produce free air in the peritoneal cavity. We call it pneumoperitoneum, medical term. It's called pneumoperitoneum. Okay. So কি দেখবে? X-ray তে কি পাওয়া যায়? We can see free gas under diaphragm. It may be unilateral, it may be bilateral. Free gas under diaphragm, under the domes of diaphragm. This is the classic signs. Rest 3 sign I won't ask anyone in the exams except in the gold medal exams. So last 3 for gold medal exam only. First one for passing. If you can't tell this one, I won't pass anyone. Okay. Last 3, even if you don't say, I don't mind anything. Okay. But you have to tell the signs of pneumoperitoneum is free gas under diaphragm, under the domes of diaphragm. Maybe unilateral, maybe bilateral. This you have to say. Okay. For passing. Huh? Okay. Now, see. This is a good X-ray, bad X-ray? Not so good. Didn't include this. But anyway, is serving for free gas. At least domes of diaphragm are included. So at least we can make, there are, what is this? This is the diaphragm. This is liver. So this is free gas under diaphragm. Normally there is no free gas under diaphragm. Both are liver and diaphragm. If you do an X-ray, you will see they are same. So this is free gas. What is this? This is gastric bubble, yeah. So there is free gas under diaphragm. Okay. So this is an X-ray and this is a chest X-ray. Now, if I ask you which one is a better modality for detecting intraperitoneal free air, abdominal X-ray or chest X-ray? This is an erect chest X-ray. This is an erect abdominal X-ray. Huh? How many for abdominal X-ray? He is for abdominal X-ray. How many for chest X-ray? Rest are nota. But anyway, again, democracy wins. But most of them are nota anyway. So chest X-ray. Chest X-ray is more sensitive for detecting intra-abdominal free air. Can you tell me what is the amount of air, minimum amount of air that can be detected on a chest X-ray? Minimum amount of air detected in a chest X-ray. If there is free air in the abdomen, even 1 ml of free air can be detected in a chest X-ray. Because see, this is an erect chest X-ray, na? So chest X-ray includes diaphragm also. So for pneumoperitoneum, it serves your purpose. So if you suspect that there is a pneumoperitoneum, there is an intestinal perforation, you have the peritonitis class, no? Had it been taught there? In a suspected perforation, peritonitis, you should order an chest, order an X-ray. Huh? So chest X-ray is more sensitive than abdominal X-ray in detecting intraperitoneal free air. It can detect even 1 ml of intraperitoneal free air. Okay. Abdominal X-ray sensitivity is around 70%. So it can miss. Many of the perforation can be missed in an abdominal X-ray. That's why I have put both in a single frame. So if you suspect that there is a free gas under diaphragm, you should order an erect chest X-ray. Now tell me, if there is an appendicular perforation, do you expect this thing, free gas under diaphragm? Appendicular perforation. Stomach, duodenum, small intestine, large bowel. All perforation will produce free air. What about appendicular perforation, so common? Will it cause free air or not? Because appendicular lumen contains negligible amount of air. It's very small, no? So that's why it won't produce any, good amount of air, even not even 1 ml of air. So it cannot be detected normally. Okay, so appendicular perforation may not give any free gas under diaphragm. Okay. exception if it is a vesical base where the perforation size is large. That means it's mostly a colonic perforation then if it is at the base, isn't it? Appendicular base is at the colon, no? You follow the tinea, it's at the colon basically. So if it is a base perforation, only then you can have. Otherwise, for a normal appendicular perforation, you won't get any gas shadow. Okay. So suspected perforation, what X-ray will order? Erect chest X-ray, erect. If patient cannot stand, because sometimes the patient will be peritonitis, no? Sometimes the patient will be sick, they cannot move, they cannot, even some sick patient won't be able to stand also. So at least do a sitting chest X-ray then. If he cannot stand, at least ask him to sit. So it should be a sitting or erect chest X-ray. So tell erect chest X-ray. If examiner asks if he cannot stand, I'll take a sitting chest X-ray. And sometimes even if they can't sit, sometimes you can go for a lateral decubitus X-ray. But normally, see, I have not done yet. But still in examination, you can ask, the examiner can ask, you suppose if the patient is so sick that even he can't sit, how do they take an X-ray? So you can do a left lateral decubitus. The idea is the gas will rise, na? If you pass the X-ray like this chink of air will come in the X-ray. So if the examiner asks, tell this, but normally I haven't done yet. Okay. So it's always on chest X-ray. And these days we go for a CT. If you go to UK, for a suspected perforation, they don't do abdominal X-ray. Okay. Or chest X-ray. Chest X-ray is always there because, I mean, if they have to operate, so chest X-ray they will do, but they will do a CT scan. But we are a resource constrained country. We cannot order CT scan for every patient. Huh? In any advanced this thing, they will always ask for a CT. Okay. So why pneumoperitoneum is important? Are they benign? Pneumoperitoneum. Suppose some intestine has perforated. So is it a benign condition or benign? It's not malignant, but is it a very trivial issue or no? It's a serious issue. Huh? Yeah, it's always an emergency. It's always a surgical emergency. Some intestine has perforated means this is always a surgical emergency. You have to fix it surgically. Okay. Free gas often difficult to identify on the abdominal X-ray. 30% you won't find. So that's why you never forget to order on chest X-ray. Okay. But always remember, post-operative patients or a surgical patients, if you operate, if you open the abdomen, so air will be trapped inside the abdomen. So in a post-op patients, up to 1 week, there may be some free gas under diaphragm if you go and if you do some X-ray, almost up to 6-7 days. But beyond that, that X-ray, that air gets absorbed. So beyond that, if there is air, always be suspicious that there is something wrong. Okay. Otherwise, in a post-op patients where some laparoscopy has been done or some open surgery has been done, up to 1 week, patient may have evidence of free air in the X-ray or CT. Okay. So what are the other signs of pneumoperitoneum? This is for gallbladder exam. It's called Rigler's sign. See, air, normally air is only inside the bowel. So if you see the bowel shadow, only the inner wall of bowel should have air, not the outer wall. Okay. But see here, air this side also, air this side also. So that's why it's so prominent. Can you see the bowel margin? Both sides has air, black. So this is called Rigler's sign. This is falciparum ligament sign. Yeah. Falciparum ligament is normally not visible. But if there are air both sides, sometimes this is visible. But I won't ask these questions. But I will definitely ask these things. Never forget this. Okay. Now next is the bowel gas pattern. What is bowel gas pattern? B. A, B, D, O, X. So B for bowel gas. কি bowel আছে পেটের মধ্যে? Stomach, small intestine, large intestine. Stomach এর পজিশন কোথায় হয়? left upper quadrant. So this is the gastric bubble, the normal gastric bubble. What is this line? Horizontal line. Some air fluid level. So there is some gastric juices and all these. Okay. Above pylorus, how many? I mean, how much above pylorus? How much juice come? Above pylorus. Saliva কতটা হয় তৈরি? Per day saliva? Any guess? 1.5 liters. Gastric juice 2.5 liters. So above pylorus কত হলো তাহলে? 4 liters. Okay. So there is air fluid level. Okay, this is air fluid level. This is the gastric bubble. And then small intestine and large intestine. Where is small bowel located? 2 or 3 just small bowel loops, not more than that. Okay, small bowel is located centrally. Large bowel is located peripherally. Okay, so shadow here will be likely a colonic shadow, but shadow here is likely to be a small intestinal shadow. Okay, normally you can always find air in sigmoid and rectum until unless there is some obstruction. Whereas the rest of large bowel, there will be varying amount. There will be some feces, so sometimes air and feces they will give a mottled appearance. Okay. So small bowel is a central location. This is a picture of normally obstruction or ileus. You cannot differentiate on simple X-ray. Both will look same. Small intestine ileus or small intestinal obstruction. That you have to differentiate clinically. But X-ray wise, they will be all same. What you can see? Hey, don't talk, please. Listen. What you can see? Talk to me in the class. What you can see? How to know that this is small bowel? Small bowel is a central in location, number 1. Number 2, small jejunum has, what is this thing? Valvulae conniventes. These are mucosal fold. They go from one wall to another wall. See, they are full, one wall to other wall. Okay, they are complete ring mucosal folds. This is typical of jejunum. Ileal mucosa is, how does ileal mucosa look? Ileal mucosa doesn't have such prominent folds. So on an X-ray, ileal mucosa is characterless basically, no special character. But jejunum always have valvulae conniventes. Okay, so this is called concertina effect. Concertina effect. This is valvulae conniventes. And what is the normal small bowel this thing diameter? Small bowel and large bowel the car diameter come. Small bowel. That's why it's a small bowel, no? But small bowel is a longish. Diameter is less. That's why it's called small bowel. Okay. So what diameter will constitute a pathological condition? You know 369 rule? So remember 369 rule. 3 is for small intestine. If it is more than 3 centimeter, this is pathological. For large gut, it is 6 centimeter. And among the large gut, which portion has highest diameter? Cecum. Normal diameter is 8 millimeter. So if it is 9 millimeter and 9 centimeter or more, this is pathological. So for small bowel, this is more than 3 centimeter. For large bowel, this is more than 6 centimeter. For cecum, this is more than 9 centimeter. So this is called 369 rule. Okay. So this is ileum. Particularly this is jejunum. Okay. Now, in obstruction, you will always find this is small bowel or large bowel? Small bowel, because this is central in location. Okay. So if you take an erect position, erect X-ray, you can find this is a supine X-ray basically. Okay. Supine X-ray gives you a better gas pattern. Okay. And this is an erect. Because why erect? Because there are multiple step ladder pattern, air fluid level. These horizontal lines are fluid levels because there's some intestinal obstruction, no? So there will be some intestinal contents, they won't pass. So they will give some shadow also. This is air fluid level. So this is possible if you take an erect X-ray, but many of the patients, they may not stand also. So in UK, normally here in India, for obstructions, we write abdominal X-ray, erect supine. 95% people will write abdominal X-ray, erect supine. That means exposure will be, how much exposure? 0.02 is for chest X-ray. 0.7 plus 0.7. So almost 1.4 millisievert. In UK, you cannot write erect abdominal X-ray. They don't write it, their policy. Because they say all the gas pattern, they are better seen in the supine position. So for intestinal obstruction, we don't need erect posture. If you see Belly and Love, there's an UK book, so you'll find that they don't go for an erect X-ray. But in India, still, I mean, most of us write abdominal X-ray, erect and supine. Okay. But in UK, they don't do erect abdominal X-ray. You will get this pattern, air fluid level, multiple air fluid level only in erect posture, not in a supine position. Supine position will give you an idea of only the gas pattern. Yeah, gas pattern. This is not a normal gas pattern, no. You won't find a normal X-ray like this. Normal X-ray will be like this only. Like this only. So how does large intestine looks in a bowel if there is some obstruction? It's a peripheral location, isn't it? See, peripheral location. Okay, and you can see the hostra. This is it will be the transverse colon. This is the dilated transverse colon. This is the sigmoid colon. If you see the hostra usually they are incomplete. They don't go from one wall to other wall. Usually, hostras are incomplete folds. Okay, and large intestine is peripheral. So it may contain air, or sometimes it will cause fecal matter also. If there is gross amount of fecal matter, air and fecal matter both will give some mottled appearance. Okay. So this is a 369 rule. Okay. So for small intestine, see, this is the valvulic coneventties. They go from one wall to another wall. More than 3 cm, that means the small intestinal obstruction. Okay. And see the hostra. Hostra incomplete folds. Okay. They are interrupted here. Not like this, full. So this is the normal diameter, isn't it? What is the narrowest part of large bowel? I mean, you can say the sigmoid and this thing. Sigmoid, retrosigmoid, these are the narrowest part. It's a 4 cm. Cecum has the double this thing. So that's why 369. Small intestine more than 3 cm. Colon more than 6. Cecum more than, because cecum being the largest diameter. Now you remember the Laplace's law. So if there is some obstruction here, okay, if there is obstruction here, what will happen? The colon will get distended, and if the ileocecal valve is patent, that means it won't allow the air and this thing to pass proximally. That means the colon will be gradually dilated. Now, at some point of time, the pressure will be too high, and some portion of colon will just give away, giving rise to perforation. Now, tell me, if there is obstruction, which site has the maximum chance of perforation? এই জায়গাটা ধরো obstruction, তাই তো? তার মানে এখান থেকে আর এইখানে হচ্ছে patent ileocecal valve, so that the ileocecal valve is not allowing the air to go retrograde. So now the whole colon from here to here will get dilated. Now which portion of colon will have maximum chance of perforation? Cecum, sigmoid. Which area has maximum chance of perforation? Sigmoid. Sigmoid. কিছু একটা বলতে হবে। হ্যাঁ sigmoid. Cecum. Okay. Cecum. Cecum is growing stronger. নেক্সট কে পারফোরেট করবে? এখানে অবস্ট্রাকশন, এই অবধি কে পারফোরেট করবে? কিছু একটা, কি মনে হয়? কে? হ্যাঁ, কিছু একটা বলো। কে? আরে বলো না, কি মনে হচ্ছে? সিকাম। ওকে, সিকাম স্ট্রঙ্গার। তারপরে সিকাম, লাস্ট বেঞ্চ। হ্যাঁ, সিকাম। হ্যাঁ, সিকাম। There are some good sigmoid group also. Sigmoid. Now, can you tell me what is Laplace's law? Huh? Read in the physics. Remember 11, 12. What is Laplace's law? So what is Laplace's law? In a sphere, the pressure will depend on the wall pressure will depend on the diameter of the thing, the diameter of the sphere. So wall pressure কার বেশি হবে? যার ডায়ামিটার বেশি, তাই না? তাহলে যেখানে এখানে অবস্ট্রাকশন থাকে, তাহলে কার প্রেসার বেশি হবে সবচেয়ে? হ্যাঁ, সিকাম। তাহলে কে পারফোরেট করবে? প্রেসার ম্যাক্সিমাম বলে কার হবে? সিকাম। So the cecum perforates. This is a science and logic to it. It's not like guess. So if there is obstruction and IC valve is patent, obviously the whole colon will get dilated, but the wall pressure will be maximum on cecum because this will follow the Laplace's law. Okay? Okay. না ileocecal valve দেখো দুরকম হতে পারে। ileocecal valve may be patent. Patent means it will allow this antegrade flow, but it won't allow the retrograde flow. But sometimes they are not patent. In 30% patients, they are not patent. Okay, not patent means they will allow retrograde flow also. তাহলে retrograde flow হলে কি হবে? মানে এখানে যদি বেশি ডাইরেক্ট হয়ে যায়, প্রেসার দিয়ে স্মল বলও ফুলতে শুরু করবে। But that's good for the patient. Then they won't perforate then. But if it is a patent, which is true for 70% patients, if you don't relieve the obstructions, it will perforate, and it will perforate in the cecum because it will follow the Laplace's law. Okay. Now হচ্ছে densities. Okay. Different bones. You can see there is any fractures, any trauma, any কোনো fractures কোথাও আছে কিনা, and calcifications, kidney stone, gallbladder stone, and pancreas. How many of the kidney stones they are radiolucent? Huh? No. If you have 100 kidney stones, what percentage of kidney stones will be radiolucent? Radio opaque. কত percent? 90%. 90% of the kidney stones will be radio opaque. That means if you do an X-ray, if patient has kidney stone, you can see 90%. 10% you won't be able to see. Whereas in gallstones, it's just the reverse. 90% gallstones won't be picked up by X-ray because they are radiolucent. Just opposite. 90% of the kidney stone you can pick up with an X-ray. X-ray KOB, even abdominal X-ray. Okay. But in gallstones, only 10% will be radio opaque. So 10% only you can pick up with an X-ray. Just the reverse. Whereas in pancreatic calcification, 50-50. 50% will be visible on X-ray, 50% won't be visible on X-ray. Okay. See, this is a stones. This is kidney stone, nephrocalcinosis. It follows the contour of this thing. And this is an uretary stone. Can you see how the ureter comes? Ureter comes from, say, L2, L3, all the tip of this is the transverse process, no? Vertebral transverse process. See, ureter comes, এটা এক্সরে তে দেয়, এক্সরে দিয়ে বলে ট্রেস দ্য ইউরেটার। যেখানে তুমি ইউরেটার দেখতে পাচ্ছ, এখানে তো ব্যাকগ্রাউন্ড আমি লাগিয়ে রেখেছি এখানে, বাট নর্মালি তুমি দেখতে পাবে না। হাউ টু ট্রেস? সো ইস কামস অ্যালং দ্য টিপ অফ দ্য স্পাইনাস, টিপ অফ দ্য ট্রান্সভার্স প্রসেস, ভার্টিব্রা গুলো দেখো L3, L4, L5 এসে স্যাক্রোলিয়াক জয়েন্ট থেকে ইট কামস টু দ্য দিস থিং। সো এনি ইউরেটারিক স্টোনস উইল বি অন দিস লাইনস। হাউ টু সে দিস ইজ ইউরেটারিক স্টোন? সি, ইট উইল বি অন দিস লাইনস। Tip of the transverse process, come, SI joint, and then come here. Okay. So any stone on this line will be an ureteric stone. That is a landmark. It's a very commonly asked question. What is this? Stones only. I'm just giving you hints. Stones only. It's a large gallstone. So large gallstone can cause, what is this? From gallstone only. What is this? From gallstone only. What is this basically? এটা বলতে পারলে অনার্স। এটা গলস্টোন। এটা কি হয়েছে? লার্জ গলস্টোন। হ্যাঁ, না গলস্টোন, এটা গলস্টোন। 10% of that lucky gallstone which you can pick up in an X-ray. না, এটা কি? Small matter dilated or not? হ্যাঁ, dilate তো। এটা pathological or normal? It's a pathological. It's a dilated. Valvular conventi is dilated. Gallstone, na? Gallstone. So some obstructions, some intestinal obstructions along with gallstone. Have you heard gallstone ileus? I've told in the this thing, no? What is the complication of gallstone? Large gallstone can fistulate through duodenum and can come distally. Sometimes it will cause intestinal obstruction. This is a gallstone ileus. Not very common, but happens. Okay, I have come across it thrice almost. What is this? Now, see the distribution. Calcifications. আমি তিনটে জিনিসে বললাম, স্টোন দেখালাম। একটা হচ্ছে কিডনি স্টোন, তার শেপ কিরকম দেখালাম। গলস্টোন হলে কিরকম দেখালাম। আরেকটা কি ছিল অর্গান? See the distribution pancreas. You remember the pancreas? How does it? So it will be on the L1 level. See, this is a T2. This is L1. So L1 level. Pancreas goes like that. No, head is down, tail is up. So this is a pancreatic calcification. 50% of pancreatic calcification you can make in the X-rays. Okay. আজকে এই থাক নাকি? বাকি organs, X-ray is not good for organs. Sometimes you can find, say kidneys and all these, but they are not good for solid organs, X-rays. For that we go for ultrasound or CT. Okay. And different external objects and artifacts you can see. What is this? Foreign body. You can, medically, what is this? Is a DJ stent, ureteric stent. This is ureteric stent. So you can check the position of the stent. Like biliary stent also you can see, it will be high up. So this is ureteric stent. See again, ureteric stent. Okay. So you can always, medical device, any stent you can identify on the chest X-ray. On the abdominal X-ray. And what is this? Somebody told that they are coin, ingested coin. So it can show the position of the coin, and whether it has, see, this coin has passed, isn't it? Not the same patient, but obviously this normally coin passes. There are majority of the foreign bodies will pass on their own, majority. So this is a foreign body. A child has consumed coin. Okay, so just to see the progress of the coin, you can see on serial X-rays. So A, B, D, O, X. X means external objects and foreign bodies. Like this is the X.
Congratulations to all of you for passing with flying colors. And আগের দিন বোধহয় তোরা অনেকেই অ্যাবসেন্ট ছিলিস নিউমোনিয়া পার্ট 1 ক্লাসে। তো আমি লেটস রিক্যাপিচুলেট অ্যাবাউট প্রিভিয়াস ক্লাস। ওকে, সো হিয়ার আর সাম MCQ formats which you have to answer. Okay, first of all, what is pneumonia? Anyone? Definition of pneumonia? Anyone? Well, stand up and say. Consolidation is not a medical term, it's a radiological term. It's an infection of lung parenchyma, right? Without destruction of parenchymal architecture. Okay. So, a 60 years old diabetic male admitted with history of acute gastroenteritis and sepsis. On day 3 of admission, He is now complaining of respiratory distress, right-sided pleuritic chest pain, and hypoxia. The chest X-ray demonstrated presence of right middle lobe pneumonia. Although during admission, his initial chest X-ray was normal. So, the diagnosis is hospital or community? Why this is hospital-acquired pneumonia? Right, it is occurring after 48 hours of admission of hospital, right? So this is hospital-acquired pneumonia. A 25 years female admitted with a history of ingestion of kerosene one day back. Since then, she is complaining of dry cough and occasional left-sided chest pain, although she is not having any fever. So the diagnosis is community-acquired pneumonia, chemical pneumonitis, aspiration pneumonia, or none. So which one is correct? Which one is correct? Anyone? Chemical pneumonitis. So this is a pneumonitis. This is not a pneumonia because she is not having fever. So this is only an inflammation, not an infection. This is a pneumonitis. Okay. So this is chemical pneumonitis. A 70 years old, prolonged bedridden, semi-conscious patient admitted with history of cough and mucopurulent expectoration and low-grade fever for last 7 days. This is the X-ray. So, what will be the diagnosis? Is it CAP? Is it HAP? Is it aspiration, or is it none of the above? This is community acquired. Why this is aspiration pneumonia? Right, bedridden. First thing is bedridden. Second thing is low grade fever. In case of community acquired pneumonia, fever is generally of higher grade, more than 101. But as aspiration pneumonia occurs due to anaerobic anaerobic bacteria, so the virulence is less, and that's why fever is also pronounced less. Also, look at the X-ray. This is the typical site for aspiration. In recumbent position, the most dependent part is right-sided lower lobe anterior segment and right-sided upper lobe posterior segment. So this is the right-sided lower lobe anterior segment. So this is a typical site for aspiration pneumonia. Okay. So the answer is aspiration pneumonia. So the stage of gray hepatization, which day? 4 to 6, good, 4 to 6 days. Hyponatremia is associated with which of the following organisms? Is it staph? Is it mycoplasma, Legionella, or Leptospira? Which pneumonia? I have already taught in the previous class the mechanism of hyponatremia. So this is Legionella. In Legionella pneumonia, SIAD occurs, that is euvolemic hyponatremia. Okay. And among these pathogens, which pathogen causes jaundice or icterohemorrhagic fever? Which organism? This is Leptospira. Leptospira, it's called icterohemorrhagic fever. Jaundice with pulmonary hemorrhage. This is typical of Leptospira infection. Okay. A 26 years male admitted with high grade fever with cough and mucopurulent expectoration. His blood pressure is 90/60 and SpO2 is 88% on room air. He is an IV drug abuser, and suffering from infective endocarditis. So, which of the most probable etiology of his pneumonia? So, this is which type of pneumonia? Is this lobar? Is this bronchopneumonia, or is this segmental pneumonia? This is bronchopneumonia, right? There is no lobar predilection. The whole the most of the three lobes are affected simultaneously. So this is bronchopneumonia. So most probable etiology. This is Staph aureus, Staphylococcus, because 3 points are there. First is the sign is more prominent. Sign is or symptoms are more prominent than sign. Okay, there is high grade fever, very high grade fever with hypoxia and septic shock. This is the blood pressure is less than 100. So this is septic shock with high grade fever and mucopurulent expectoration. Along with that, he is an IV drug abuser and infective endocarditis patient. So, and bronchopneumonia pattern. In Streptococcus pneumoniae, there is lobar pneumonia. So, this is staphylococcal pneumonia. A 50 years old diabetic male with a known history of cystic fibrosis, admitted with complaining of fever and left-sided chest pain, along with mucopurulent expectoration. So, this is the chest X-ray. Describe the chest X-ray. This is lobar and left upper lobe pneumonia. Along with there is some cavitations. This is cavitation, right? This is cavity. The round marked with a definite wall. This is a cavity. This is a left upper lobe cavitary pneumonia. And the probable etiology, and this is the Gram stain. Okay, so the probable etiology, Pseudomonas. Why? Because the patient is having cystic fibrosis, that is, his lung parenchyma is already damaged. Also, there is left-sided chest pain and Gram stain showing the yellow greenish culture. Okay, so this is Pseudomonas. In destroyed lung or patients having lung pathology, chronic lung pathology, Klebsiella, Pseudomonas, Staphylococcus, these are the most common organisms that causes pneumonia. Okay. Then, how to do it clinic? What are the findings of clinical examinations of a patient of pneumonia? Okay. So, first, general examinations. Patient is conscious or not? Because the higher mental status, if the patient is not conscious to time, place or a person, the gradation or the severity of pneumonia is more according to the CRB 65 score. Okay, I will tell later what is CRB 65 score. Then temperature is obviously raised. There are some few exceptions where temperature may not be raised, which are pneumonia caused by atypical pathogens like Mycoplasma, Legionella or any anaerobic pathogen, or patients with pneumonia with immunocompromised state, that is uncontrolled diabetes or HIV, they have no raised temperature in their clinical history. Okay. Tachycardia, heart rate will be more than 100 beats per minute. Respiratory rate will be more than 28 per minute. Blood pressure, systolic blood pressure, if the systolic blood pressure is less than 90 or the diastolic blood pressure is less than 60 or the mean arterial pressure is less than 65 millimeter of mercury, then the patient is having septic shock. So this is again a classification of severe pneumonia. Okay. The patient is cyanosed or not. Which cyanosis occurs in this kind of patient, peripheral or central? Central cyanosis. So the cyanosis will be recovered by putting oxygen, right? Clubbing present or not? If the clubbing is present, then there are some associated pathologies like the patient may having bronchiectasis or lung abscess or empyema pass in the pleural cavity. Okay. Next, jaundice. Which pneumonia is yes, leptospira with hemorrhagic pleural effusion, right? Neck gland. Generally, lymph nodes are not palpable in any community acquired pneumonia, but in tuberculosis is also a pneumonia. This is a kind of bronchopneumonia. Neck glands may be palpable. Okay, they are conglomerated, that is attached with each other, and they cannot be separated. Okay. In respiratory system examination, inspection, the shape will be normal except if the patient is COPD patient, the chest wall is barrel shaped. Okay. Movement may be restricted due on the pathological side. If the patient is having left-sided pneumonia due to intense pain or pleural effusion, movement may be restricted on the left side. Symmetry, if the patient is having massive pleural effusion along with the pneumonia, the pathological site will be asymmetrical. Respiration, the patient generally having tachypnea and accessory muscles are working. In palpation, vocal fremitus can be heard in pneumonia, but it's maybe obscured if the patient is having pleural effusion along with that. Okay. Percussion, dull note in the region of pneumonia affected lung can be heard. Okay. Maybe stony or woody dull. In auscultation, there will be bronchial breath sound. What are the types of bronchial breath sound? I have taught. No. Vesicular is another type of breath sound. Amphoric, right? Tubular, cavernous, and amphoric breath sounds, bronchial breath sounds. So, in pneumonia, generally, tubular bronchial breath sound can be heard. Crackles. Crackles can be heard during the initiation of the pneumonia phase, that is called index crepitus. This is more finer than the later stage. Finer crepitations generally during the early inspiration. Okay, and during the recovery phase, the patient may have a redux crepitus that is more coarser than the initial phase. So this is called redux crepitus. First is index and second is redux crepitus. Pleural friction rub may be heard at the lateral portion of the lung, and vocal resonance will be increased. Let's come to radiological investigations. Although this is not a class of chest X-ray, but I'll give you some basic ideas of how to read X-ray. Okay. So chest X-ray have 4 different views: PA or posterior anterior view, AP or anterior posterior view, lateral view, and lateral decubitus view. I'll discuss them in later classes. Okay. So this is a PA view of posterior anterior view of chest X-ray. First of all, you have to determine whether the X-ray is taken in right position or not. How to determine that? So this is the spinous process. This is the spinous process, and this is the clavicle, right? This is the clavicle. So the distance between the clavicular end and the spinous process, bilateral side, will be equal. Understood, everyone? So this is the spinous process and this is the clavicle. The distance between the clavicle and spinous process and this side clavicle and spinous process will be similar. That means the the position is absolutely normal. The patient is not rotated. Okay. Then you have to determine whether there is any pathology in. First of all, you should read the X-ray from outside to inside, from skeletal, bones, from skin, and then soft tissue, trachea, followed by lung parenchyma and diaphragm. This is the method of reading X-ray. Okay. So this is the, what is this? This is the head of humerus and this is the shoulder joint, right? This is the scapula. This is the scapula and these are the ribs. This is the breast shadow. This is the spinous process and this is the vertebra. The esophagus, this is the trachea. Trachea. This is the trachea and this is the lung parenchyma proper. Okay. So in lung parenchyma, this is the hilum. This is the right hilum and this is the left hilum. Right. And this is the pulmonary artery. This is the pulmonary artery. This is the hemidiaphragm and this is another hemidiaphragm. Okay. And this is the heart shadow. Okay. This is right atrium. This is left ventricle and this is left atrium. Next. This is cardiothoracic ratio. What is that? By cardiothoracic ratio, you can determine whether the patient is having cardiomegaly or not. Okay. So, how to calculate this? Draw an imaginary line along the spinous process. This is the imaginary line. Okay. So, the distance from the imaginary line to that of the hilum, right hilum and the left hilum, A plus B, divided by distance of the between the two hemidiaphragm, A plus B divided by C. This is the cardiothoracic ratio. Okay. So this is generally less than 0.5. Less than 0.5. A plus B less than 0.5 of C. This is normal. If the A plus B is more than C or more than 0.5 half of the C, then you can call it the patient having cardiomegaly, right? Huh? A plus B more than 0.5 of C, half of C. Okay. Just look at this X-ray. The patient, suppose this is the imaginary line of spinous process. You can draw a line from A and this is the heart border, left heart border. So this is A and this is B and this is C. So you can easily appreciate this A plus B is more than 0.5 of C. This is cardiomegaly, right? And there is in situ pacemaker. Okay. And the lead of the pacemaker is in left ventricle. This is single chamber pacemaker. So the patient is having cardiomegaly along with heart failure, because you can easily appreciate that the congestion, these are the hilar congestions, this is not normal as like this parenchyma. This is not normal, right? There are some opacities, irregular opacities, but the opacities are distributed along the hilum. They are not touching the periphery, right? So this is perihilar consolidation with cardiomegaly. This is not a pneumonia. This is a typical X-ray of heart failure or pulmonary edema. Just follow the next X-ray. So this is the next X-ray where you can easily appreciate the periphery of the lung is also involved and also the hilar part, right? The cardiothoracic ratio is almost normal. So this is a pneumonia. This is a pulmonary edema and this is pneumonia, right? Because the perihilar part is along with the peripheral part are also involved in pneumonia. Also, you can easily appreciate there are some black and white dots. These are the black dots and these are the white dots, right? You can see, na? So this is called air bronchogram. Air bronchogram. This is pathognomic of pneumonia or consolidation. So this is right lower lobe pneumonia. Then what are the types of pneumonia, or what are the anatomical classification of pneumonia? Anyone? Anatomical. Lobar pneumonia, bronchopneumonia, segmental pneumonia, right? So is this a pneumonia? Is this a pneumonia? Yes. Is this a pneumonia or not? Huh? This is not a pneumonia because there are no air bronchogram. Can you appreciate any air bronchogram over there? Any black shadow or any white shadow? So this is a lung mass, right upper lobe mass. This is not a pneumonia. This is a pneumonia, right? There are air bronchograms. So this is lobar pneumonia. This is the horizontal fissure, and this is right upper lobe. So this is a right upper lobar pneumonia. Next, this is which type of pneumonia? This is bronchopneumonia. This is lobar pneumonia, and the typical of these kind of pneumonia is, you can easily appreciate the fissure. This is the fissure. The fissure bulges downward, right? This is the normal fissure, and the fissure is bulges downward. This is a bulging fissure sign of pneumonia. This is typical of Klebsiella pneumonia. Klebsiella pneumonia. And this is also pneumonia. You can see there is a cavity, a defined wall, along with that inside a consolidated area. This is called cavity. This is a cavitary pneumonia. Okay, so cavitary pneumonia or necrotizing pneumonia. There are some certain pathogens causing cavitary pneumonia or necrotizing pneumonia, like staphylococcal pneumonia, tuberculosis, Mycobacterium tuberculosis, Klebsiella, Pseudomonas, and some anaerobic pathogens also. They cause cavitary pneumonia or necrotizing pneumonia. You can also easily appreciate the resolution. This is one of my patient having admitted with this type of pneumonia, right-sided bronchopneumonia, and after proper antibiotics, this is the resolution. Okay, after 4th day of antibiotic. So you can easily appreciate the resolution also. Now, after confirmation by radiological investigations or X-ray, you should do a proper microbiological examinations to determine the etiology of the pneumonia, right? How can you do that? You should ask for sputum samples, blood samples, urine samples also. Okay, so sputum examination. Mind it not to collect saliva, okay, because if you collect saliva, the result may be erroneous and the proper pathogen will not be demonstrated in gram stain. So proper collection of early morning mucopurulent expectoration is needed to diagnose the pneumonia. Also, how to differentiate that you have not collected saliva? If the buccal cell, sputum buccal cell is noted down, you will not find it in any book. Okay, note it down. and I'll not share my slides. Okay. So if the buccal mucosal cell is less than 10 under microscopy, along with that the neutrophils more than 25 per low power field, then it is not saliva, it is good sputum, or it is mucopurulent expectoration that can be cultured. Okay, and gram stain can be done. So send the early morning sputum for gram stain culture sensitivity, for 2 days acid fast bacilli stain, that is Zn stain or fluorescent stain, any one of these, fungal stain and culture. Not always fungal stain is needed, especially in certain populations like in HIV or immunocompromised individuals, in prolonged hospital stay or hospital acquired or ventilator acquired pneumonia, associated pneumonia, fungal stain is needed. Otherwise, fungal stain is not needed in every community acquired pneumonia. Okay. Also, many of the patients cannot expectorate sputum, so you should nebulize them with hypertonic saline and do proper chest physiotherapy to expectorate the sputum, or else you can do a bronchoscopy and take bronchoalveolar lavage for examinations. Okay. Then blood and sputum culture. So always sputum and blood samples to be collected before the first dose of antibiotic. Okay. Although the sensitivity is not too much good in Streptococcus pneumonia, the Staph aureus yield of sputum CS in Staph aureus or Klebsiella is much more than the Streptococcus pneumonia. So the main problem is to isolate the commensal flora. Commensal means those organisms which are inhabitant of our upper airway. Okay. The colony count must be more than 10 to the power 5 colony forming unit per ml. In case of bronchoalveolar lavage, it will be more than 10 to the power 4 colony forming unit per ml. Blood culture simultaneously aerobic and non-aerobic culture should be sent. If you collect blood for culture and sputum simultaneously before the dose of first antibiotic, the yield will be much higher. Okay. Urinary antigen. You have any idea in which pneumonia we can test for urinary antigen? Streptococcus one, second is Legionella and Streptococcus. These are the two pathogens in which we can test for urinary antigen. Okay. There is certain advantage of this urinary antigen over the culture, because these both tests can detect antigen even after the initiation of antibiotic. But this is not in our regular practice due to non-availability, or due to these tests are costly also. So this is reserved for severe cases. Sputum immunodetections. In microbiology, you have read about immunodetections like immunofluorescent antibody test, diffuse immunofluorescent antibody test. So this is also to detect Legionella, Chlamydia and there is also advantage that antibiotic initiation of antibiotic does not hinder their sensitivity. The PCR, the DNA PCR test mostly to detect viral pathogens like SARS-CoV-2, COVID or influenza. Also, some bacterial pathogens like Legionella, Mycoplasma, Chlamydia and Mycobacterium tuberculosis also can be detected by PCR technology. In Mycobacterium, there is a test called Gene Expert or CBNAT test. So this is a PCR technology. And serology, if there is fourfold rise of IgM antibody to a specific organism, that is mostly Coxiella. So Coxiella Q fever. So this is for Coxiella burnetii. But it's hard and difficult to interpret, and it's not cost effective as well. So it's not in our routine practice. Then blood investigations. You should do routine blood investigations like complete blood count. In complete blood count, you can see leukocytosis or leukopenia. Leukocytosis, that is WBC count more than 11,000, or leukopenia is less than 4,000. And neutrophilia along with left shift of neutrophil, that is immature neutrophils or the presence of toxic granules. Leukemoid reaction সব সময় বলে না তো this is indicative of severe infection, severe bacterial infection in neutrophilia or left shift of neutrophil along with toxic granules. And if there is lymphocytosis, maybe the organism is viral or atypical pathogens. Renal function test, if the BUN or blood urea nitrogen or the urea and creatinine is raised, then the pneumonia is classified as severe pneumonia. Electrolytes, hyponatremia, as I have already mentioned, in Legionella pneumonia and also in pneumococcus, hyponatremia may occur. The inflammatory markers, if the C-reactive protein is more than twice of the normal value or the procalcitonin is more than 0.5, that indicates the infection is severe and the patient needs proper antibiotic dosage. Procalcitonin also helps to de-escalate and escalate the antibiotic therapy. If you give antibiotic and after 2 days the procalcitonin is more than 0.5 or more than 1, then the antibiotic dose is not proper and you have to escalate the antibiotic. Likewise, if the PCT or procalcitonin is less than 0.5 after 48 hours of the antibiotic initiation, then you have to de-escalate the antibiotic. Okay. Arterial blood gas. You have read in your biochemistry classes how to interpret arterial blood gas. You have not read? জানিস না তোরা বায়োকেমিস্ট্রি ক্লাসে? ফিজিওলজিতে হয়েছে? ক্লাস হয়েছে? ঠিক আছে, আমি নেক্সট ক্লাসে আমি এবিজি পড়িয়ে দেবো, ঠিক আছে? সো ইন এবিজি মোস্টলি দেয়ার উইল বি টাইপ 1 respiratory failure. Type 1 means PO2 less than 60 millimeter of mercury. And the PF ratio, what is PF ratio? PO2 by FiO2 ratio. FiO2 means how many liters of oxygen you are giving to that patient, and PO2. This ratio is less than 300. If it's less than 300, then the patient is having severe pneumonia, and he is developing acute respiratory distress syndrome or ARDS by pneumonia. This is the most important score you have to do in each of the pneumonia patients. Okay. So this is the CURV 65 score. C means confusion, which I have mentioned earlier. The confusion. U means urea is more than 7, respiratory rate more than 30, and systolic blood pressure is less than 90 or the MAP is less than 65, and the age will be more than 65. If the cumulative score will be more than 3, then it's termed as severe pneumonia and the patient should be treated in ICU. Okay. If it's between 2 to 3, it's less than 3 but more than 1, the patient should be admitted but not in ICU, in ward. And if it's less than 1, the patient should be treated in OPD basis by giving antibiotics. Also, there is another criteria for severe pneumonia. Write down these criteria. These are very important criteria. Okay. This is CURV 65 score. CURV 65 score. Okay. More than 3 or more than 3 means the pneumonia is severe and the patient should be treated in ICU setup. Less than 3 but more than 1 means the pneumonia is moderate and the patient should be treated in non-ICU but should be admitted in IPD. And 0 to 1 means should be treated in OPD basis. This is the criteria for severity of community acquired pneumonia. So there are the minor criteria and these are the major criteria. If more than 3 minor criteria or any one of the major criteria is fulfilled, then the patient is termed as having severe community acquired pneumonia. Okay. So these are the minor criteria. If the patient is having tachypnea or hypoxia, that is PF ratio, as I have already mentioned, is less than 250. PO2 by FiO2 ratio is less than 250. Multilobar infiltrates, that means bronchopneumonia. Confusion, that is similar with the curve score, confusion. Uremia, that is blood urea nitrogen level is more than 20. How to interpret the BUN level from urea? In biochemistry classes, urea divided by 2.6 is your BUN level. Urea divided by 2.6. Okay. Leukopenia, if WBC count is less than 400 and absolute neutrophil count ANC is less than 1000, it's severe pneumonia. Okay. Thrombocytopenia, if the platelet count is less than 1 lakh and if the patient is having hypothermia less than 36 degrees centigrade or hypotension, that is systolic blood pressure is less than 90 or diastolic blood pressure is less than 60 or mean arterial pressure is less than 65. But mind it, not requiring any vasopressor support, any noradrenaline or any dopamine or any vasopressor support. Just this hypotension can be managed by giving antibiotics and fluid resuscitation, not requiring any vasopressor. So these are the minor criteria. But the major criteria are the patient is too much hypoxic that he requires invasive mechanical ventilation. Okay, the PF ratio, PO2 FiO2 ratio is less than 200 and is diffusely cyanosed, that the patient may require invasive mechanical ventilation. Also, there is septic shock. Despite of adequate fluid resuscitation and antibiotics, the patient is having systolic blood pressure persistently below 90 and diastolic blood pressure below 60, and he needs vasopressor like noradrenaline, dopamine or vasopressin to elevate the BP. So these are the criteria. If 3 of the minor and or 1 of the major criteria are fulfilled, then it is termed as severe community acquired pneumonia. So this is another score. This is called PSI score. You need not to remember all those categories. Just remember the name PSI, that is pneumonia severity index. If the pneumonia severity index score is more than 130, then the mortality rate will be higher. Okay, and if it's less than 50, then the mortality rate is not as high, and this can be treated in OPD basis. Okay, so this is PSI or pneumonia severity index. Pneumonia severity index. এত কিছু মনে রাখতে হবে না, স্কোর মনে রাখার দরকার নেই, জাস্ট পয়েন্ট মনে রাখবি যে if it's more than the total point, this 10 plus 20 plus 30, like if any liver disease, the patient, the point will be plus 20. If any renal disease, plus 10. Likewise, you can sum up the all scores, and if the total score is more than 150, then it's called severe pneumonia or grade 5 pneumonia, severe pneumonia. If it's less than 50, then it's not severe and can be managed OPD basis, right? Now, let's look into some complications of pneumonia. So, local complications and systemic complications. We all know pneumonia is a infection of lung parenchyma without destruction of lung parenchyma, right? So, the infection, if left untreated, may result into pleural effusion, or that is called parapneumonic effusion, or pus coming out from the pleural cavity, that's called empyema. Pus in pleural cavity, that's called empyema. And effusion associated with the pneumonia, that is not pus, but it's due to pneumonia, that is called parapneumonic effusion. There are certain types of parapneumonic effusions like simple parapneumonic effusion, complicated parapneumonic effusion. Thereby, and if the complicated parapneumonic effusion is left untreated, then it will be turned into empyema or pus inside the pleural cavity, right? So this is the serous fluid aspirated from pleural cavity, and this is the empyema. This is pus. Okay. So this is the X-ray. You can easily interpret that there is a pneumonia. This is right middle lobe pneumonia. Along with that, this is the costophrenic angle. The costophrenic angle is blunt, whereas in left side the costophrenic angle is not blunt. So this is effusion. This is mostly parapneumonic effusion. Okay. Lung abscess. If the parenchyma is totally destructed, it's a parenchymal pathology. It's totally destructed, and there is also necrotizing pneumonia along with that. The parenchyma will be converted into a abscess cavity. This is the lung abscess. This is the right upper lobe, and there is, you can easily appreciate, there is a cavity. There is a wall. This is a cavitary wall, and this is a air fluid level. This is a horizontal straight level. This is called air fluid level. You can find it in abdomen also, right? In subacute bowel obstruction or acute intestinal obstruction, you can find numerous air fluid level in straight X-ray abdomen. Likewise, this is a horizontal air fluid level, means there is a presence of fluid, that is pus, along with some air due to necrosis. So this is air fluid level. This is called lung abscess. I will discuss in next class what is lung abscess and its complications. লাং অ্যাবসেস হতে গেলে ফার্স্টে ক্যাভিটি হতে হবে। ক্যাভিটি আগে যে নেক্রোটাইজিং নিউমোনিয়া দেখালাম, ওই নেক্রোটাইজিং নিউমোনিয়া যদি হয় এবং দ্যাট ইজ লেফট আনট্রিটেড, এই পাস অ্যান্ড এয়ার উইল বি অ্যাকুমুলেটেড ইন দ্য ক্যাভিটি and forms a air fluid level. Air and fluid means pus. ঠিক আছে, So this is lung abscess. So what are the systemic complications? Sepsis. If the patient is having severe pneumonia, the patient can go into sepsis. That means his total WBC count is more than 12,000 or less than 400. He is having fever. Sepsis means temperature is raised, tachycardia, tachypnea, and WBC count is more than 12,000 or less than 400. This is called sepsis or SIRS criteria. SIRS, Systemic Inflammatory Response Syndrome criteria. This is SIRS criteria. Also, if left untreated, may result into septic shock. That means sepsis along with shock means systolic blood pressure is less than 90 or diastolic blood pressure is less than 60 or the blood lactate level is more than 2. These are the determining factor of shock, septic shock. Also, multi-organ dysfunction, it can affect heart by causing infective endocarditis, by causing myocarditis or pericarditis as well. Can affect liver by causing transaminitis or acute liver failure. Can cause kidney injury, like can increase creatinine level or can cause anuria or oliguria, and can also dysfunction the CNS, central nervous system, by causing confusion. So multi-organ dysfunction syndrome may happen. Followed by septic shock. As I already taught, what is septic shock? Infective endocarditis, especially in staphylococcal pneumonia, infective endocarditis is a known complication of untreated staphylococcal pneumonia.
Perhaps this is not the new class, is it? What I remember, I have discussed once with you about the evaluation of health promotion and education program. Before starting to discuss about the evaluation of health promotion and education program, you should know 3 terminology. What is health promotion? What is health education? And what is evaluation? Is it? So the terminology. The terminology evaluation is not new to anybody else. Everybody knows what is evaluation. Evaluation means what? Can anybody tell me what is evaluation? In Bengali we call it Bangladeshi ki bole Mullayon. Okay. So there are different procedures or steps to evaluate anything else. Suppose the University of Health Science is interested to evaluate your knowledge, evaluate your skills. Is it? How they can evaluate? To different types of examinations. Okay. So before that, what we do? We try to assist you in gaining knowledge, acquiring skills in different ways, either through lecture discussion or through group discussions or through one-to-one situations, through demonstrations. Okay? Now, তোমরা আশা বন্ধ না করলে আর কি করে হবে? তোমরা আশা বন্ধ করো। Likewise, in order to, or if you want to improve or promote health of the community or other people, I can say, apart from the normal existing infrastructure, we have to organize different types of health promotional programs to promote health of the community. There are different types of health programs. To organize any program, apart from the technical things, we require money or budget. So that budget is provided by the government of India as well as the state government. Sometimes few programs used to organize through 50-50 basis, and sometimes state-owned program, sometimes central-owned program. Whatever may be this. But you see, once we organize health education or health promotion programs, তোমরা তোমাদের হয়েছে, তোমরা বসো একটু। We have to evaluate the process of implementing or organizing program as well as the impact. The process as well as impact. Okay, so we call it this process indicator through outcome indicators. Okay, but you should know what is health promotion. Very many times it has been discussed by different faculties, by different faculty members in different occasions, in different situations. Is it? Health promotion is a process of enabling people to gain control over the determinants of health and improve health. At the same time, you should know about what health education is. It's a process of changing the behavior of the people. Okay, so in order to do that, for health promotion as well as for effective health education program, we should have the ability or the capacity to assess the process as well as impact of any program. So what is the difference between process and impact? Number one, the process. Suppose you are in the class, we are trying to help you to gain knowledge, to acquire skills. How we are helping you? By organizing different types of lecture class, by organizing small group discussions, through demonstrations. So these are the process. One. And secondly, we have the infrastructure, the classroom, the audiovisual systems, the LCD projectors. So these are the process. Okay. And at the same time, impact evaluations. What is that? At the end of the sessions or at the end of the year, university organize examination to assess the impact what we are trying to do throughout the whole year. Likewise, in each and every program, this is an educational program, fine, and that is an health education and health promotional program. All the same, content will be different, the process will be the same. Okay. Now let's proceed. Program evaluation, what is that? Program evaluation is the systematic gathering. Number one, systematic gathering. That means in a systematic way, we are gathering what? We are gathering data or we are gathering information. Once we collect information, then we are analyzing it. After that, we try to interpret it, and then we make reports and disseminate this report to assess the impact of this program. So that is called program evaluation. Program evaluation is the systematic, quote unquote, is the systematic gathering, analysis, interpretation and reporting of data about a program to assist in decision making. That means once we organize a program, we have to assess the impact, otherwise we cannot improve the program, or we cannot tell that yes, there is a effectiveness of this program. For this program, something has been improved. It includes both qualitative and quantitative data collection. Perhaps right now you have the idea about quantitative and qualitative data. In statistics class, it has been discussed. So what is qualitative data? What is quantitative data? Just I would like to ask you, otherwise how I can proceed. We have to take the help of mixed methods. Previously, we used to collect only quantitative methods, but nowadays we use both the techniques. Hello. Both the techniques, okay? Both types of data we collect. One is qualitative data, another is quantitative data. What is qualitative data? What is quantitative data? Anybody else? It has been taught since the beginning. Data. What is data? বলো তথ্য কাকে বলে? What is data? What is data? Now, if you cannot answer, how I can proceed? It's very difficult. আমার ভুলে যাওয়া হবে. What is data? Nobody. What is data? Data means nothing but information. It is information. So what type of information we should collect? Both qualitative and quantitative. Quantitative means the data that we can express in terms of numbers. 1, 2, 3, 4, 50%, 60%, 70%, 10 এর মধ্যে 8. Okay, this is quantitative. And in case of qualitative, only we are trying, or always we are trying to answer the question why it is caused, why it happens. Through qualitative data, we try to get the answers of the questions like why. So in order to evaluate anything, you have to collect both qualitative as well as quantitative data. This type of evaluation or collection of information is required to design or improve the effectiveness of any health promotion efforts or health promotion programs. Now steps. That is the topics of discussion for today. Steps of evaluating a health promotion and education program. Okay. So usually there are 10 steps. All the steps we can divide into 3 classes. One is planning, next is implementation, and last one is utilization. Whenever we do any work, we used to plan the work first. Planning is most important. Once planning is done in right way, then we can proceed further for implementation. Again, if we can implement the right way, then automatically we can expect the positive impact of your work. Then results will be good. Result will be positive. So all the steps can be classified into 3. One is planning, and then implementation, and third one is utilization. So under planning, there are 6 steps. First one is clarify the program. Whenever we try to assess the program, we have to clarify the program to whom? To the beneficiaries for whom the program is meant. And second one is engage stakeholders. Stakeholders means nothing but beneficiaries and other persons also who are directly or indirectly involved in this program. So next one is engage stakeholders. এই তোরা যদি কথা বন্ধ করে না কিছু আমি চুপ করে থাকবো। জিজ্ঞেস করে তো একটাও কিছু বলতে পারছো না। পরীক্ষার সময় কি হবে ভগবান জানে, আর তোমরাই জানো। Okay. First step is clarifying the program. Second one is engage the stakeholders. Third one is assess resources and availability. Rather, we can say assess the resources and availability. And next one is fourth step, determine your evaluation questions. And fifth one, determine appropriate methods of measurement and procedures. And last one in planning stage, that is develop evaluation plan. So first what we have to do, we have to clarify the program among the stakeholders as well as the person concerned who are trying to evaluate the program. Second one, engage stakeholders. That means you have to engage, you have to question, you have to ask many more things to those who are directly or indirectly engaged or who are directly or indirectly expected to be benefited from this program. We have to ask them. And third one is assess resources and availability. Whether the resources that are available, is it sufficient to evaluate the program? And next one is determine the evaluation questions. What type of question we have to frame? Whenever we conduct any study, this is nothing but a study, evaluative study. There are different types of study. So one type of study, evaluative study. In case of evaluative study, objectives will be there. Whenever we start anything, there will be objective. In case of evaluative study, we try to assess how far the objectives of the program that has been implemented or already over is successful or how far it is achieved. That is evaluative study. Here also the same thing. It's no difference. So determine your evaluative question. What are the questions that you should frame on the basis of which you can expect to get the answer? Whether your program has been successful or how far it is successful or how far your objective is achieved or not. Step 5, not only to frame the question, but you have to determine what procedures, what methods you will follow, what techniques you will follow to collect the data. Data must be relevant. And last one, in planning stage, then you have to develop an evaluation plan. Plan means a blueprint, nothing but on the basis of which you can proceed, you can work. Whenever you construct a house, what do? We plan. Where will be your dining space? How many rooms will be there? In which corner kitchen will be there? Whether the kitchens will be this open kitchen? How many lobby will be there? Where you will keep LCD projector? Where you will keep radio? Where you will keep TV? Okay, so you have to sketch it, you have to plan it, you have to pass it from the appropriate authority, then you start work. Likewise, same things. You have to develop an evaluation plan, okay, and you have to take the help of the experts, check it, approve it, then you can start your work. Start your work means implementation. Collect data. So on the basis of the question, following the different procedures that will determine that results will be good, you start to collect data, that is data collection. Okay, that is up to, that is implementation, collect data. And next, once you collect data, what you do? Everybody almost, I think everybody has collected data, is it? In second year or like that, in your clinical programs, you have collected data? Koroni from this OPD. So that is data collections. Once you collect data, then what you did? You process the data. You process the data. So next step is process and analysis the data. Okay. And then question come about interpretation of the data and presenting your findings. And last, apply evaluation findings for the further improvement of the program. Is it clear? So there are 10 steps. These 10 steps are very important. First one is clarifying the program. Before starting any evaluation program, you have to clarify about the program to the data collection personnel, as well as from whom you are collecting data, or rather not only from whom you are collecting data, but the persons or the organizations who are engaged or who are the beneficiaries or who get or who are expected to get the benefits from your program that has been implemented by your organization or your group. So you have to engage them. And third one, you have to think, now is it ready to evaluate this program? Assess resources, and what are the resources? Is it feasible? Is it practicable to assess the program? Then, if it is yes, then go further. The fourth step, determine your evaluation questions. What type of questions you will ask? In your examinations also, same thing. The paper setters used to set the papers, expecting that these questions will cover all the syllabuses, and with these questions, it is possible to evaluate the knowledge, the skills of the students. Likewise, you have to determine your evaluation question, and then once question is set, the next step is what procedures you will follow, what procedures or methods or measurements you will follow, how to measure your knowledge, either through theory examinations or both theory and practical examinations, or through OSPE, whatever may be, okay? Through trial and error methods, they have already decided what procedures and methods that will be used. Here also, in case of evaluation of any program, you have to determine appropriate methods of measurements and procedures, and then you have to chalk out a plan or develop a plan, like your examination schedules, okay, in which room, how many candidates will sit, who will be your invigilator, what about the timing, date, etc., etc. Likewise, develop evaluation plan. Then question comes about implementation, collect data. Once you collect data, then you have to process the data. Then process means what? Once you have collected data, raw data you have collected, is it? Once you have collected data, that data are raw data. From the raw data, you have classified the data. Then you have tabulated the data. That is called processing of data. Then you have to analyze it, and then question comes out, interpretation. Interpretation of the results, and then you have to disseminate your results through presentations of your program. And last, you have to submit the report. On the basis of the report, we will take action. Likewise, in case of evaluating any health education, health program, same steps you have to follow. Okay. For clarification, if you can remember these 10 steps, your purpose will be served. First one was clarifying the program. Whom to clarify? This step is about forming a strong foundation for program evaluation. It is important to assess whether your program is ready for evaluation or not. That means whether you are ready to appear at the examination. First we have to think or assess. Then only we start your evaluation. It means gathering information about the program and sharing it with the stakeholders. Why it is important? To plan a program evaluation, you need to clarify about the program and what it was intended to achieve or what it was intended to accomplish. For that reason, আমাদের যে objectiveটা ছিল, how far the objective has been achieved, to assess that we try to evaluate what was your objective. If I give examples from you people, what is your objective at the end of these sessions, at the end of this MBBS course? The students will be able to know this, able to acquire these skills and apply these skills in helping people to become healthy or helping people to prevent disease and prolong life. What you will do? What you have to do? If you want to clarify the program to your stakeholders as well as all our stakeholders as well as the person concerned who will collect information. So you require a summary, executive summary of the report. So once the program will be over, you have to submit a report. In each and every report, there will be a summary. So you require this executive summary and hand over to it to the stakeholders or to discuss with the stakeholders about what was the program goal. Number one. Number two, population of interest of the beneficiaries. Who were the beneficiaries of this program? Number three, what were the outcome objectives? Outcome means an outcome objective spells out how much of what should happen, how much of what should be happen, by whom, to whom, by when. Next, what will be the strategy, activities and assigned resources. And last one is what was the process objectives or output. A process objective is what? That tells you how much of what you will do or produce, for whom, by when. Is it clear? How much of what? Out of 100%, how much? Say for 80%. You will produce or achieve. For whom? For the beneficiaries. By when? Within 1 year or within 2 years. Process objective is sometimes called output. Next one is engage stakeholders. You should know who are the stakeholders. Stakeholders means not only target audience. Stakeholder means a person or group of persons or organizations who are directly or indirectly get benefit from the program. Okay. In this step, consult stakeholders about their interest. Now, what you will do with the stakeholders in order to assess your program? Few stakeholders you have to engage right from the beginning of the evaluation. That means in each and every step of evaluation, you will engage them throughout the planning, implementation and use of the evaluation. Some are just at key points, not always. Now, this is a stakeholder will. That means for any program, how many group of persons will be involved in any program evaluation. First group is core group. They will be involved always, right from the beginning throughout whole evaluation procedure. Core group, out then bigger circle, just bigger. Next is involved. They are not the core group, but they are involved in your program evaluation. Then next one is they are not involved directly, but they are always supportive. Always they support your program evaluation. Whenever you go and ask them, okay, they will cooperate only. And next one is peripheral. Okay, they will help you whenever you will go. Their attitude will not be negative. And last one is private sector. You have to engage private sector. you have to engage government sector, you have to engage health sector, you have to engage non-health sector, and you have to engage community people. Okay, so these are the stakeholders who will. So these two steps are over. First one, what was the first one? Clarifying the program. Okay. Second one, engage the stakeholders. Now start about the third step. Once these two steps will be over, start third step, assess resources and availability. Whether you and your stakeholders should have a general sense of evaluation and of questions that would be of interest. Next one. There are two main tasks of this step. Number one, whenever you desire to evaluate any program, you require resources that is required. Identify the resources available for the evaluation. And next one is determine whether evaluation is appropriate for your program now, or you will give some time to pass, then you will evaluate. At this stage, you and your stakeholders should have a clear understanding of the program. How do you do this? Step number 4, select and refine evaluation questions. Step 4 is determine your evaluation question. Select and refine your evaluation question. That means setting question and refine it. Next one, determine appropriate evaluation methods, procedures or approaches. Step 5, determine appropriate methods of measurement and procedures. What are the appropriate methods of measurement? In this step, you will decide what to measure to assess the impact or to assess the effectiveness of the program, what things we will measure and what procedures we will follow. Two things, what things we will measure and how it will measure. In other words, this includes how you will measure, when you will measure and from whom you will collect data. How you will collect data, when you will collect data, from whom you will collect data. Why this step 5 is important? This step focuses on 3 key areas. Number 1, select the most appropriate indicators of your program. Perhaps you have the idea about the indicators. First year or second year, you have studied the indicators. Select the appropriate indicators for your program. Collect your data at the right time, in the right way, and consider or rather from where you will collect data. Now, you need to make, how do you do this step? 4 key questions to complete this step. Number 1, how you will collect data. Whether data will be qualitative in nature or quantitative in nature or mixed. Next one, what you will measure. When you will collect data, from whom you will collect data. So 4 things you have to consider. What data you will collect, qualitative, quantitative or both. Next one, what you will measure, what change you will measure rather. And next, at what time or when you will collect data, from whom you will collect data. Now, indicators. At first I told you about the indicators, process and impact. So, process and outcome indicators. Process indicators help us to understand how a program is performing or meeting an agreed standard. That is process indicators. If I give one example from your point of view, how your class is running. In a week, how many classes are going on? Whether your faculty are able to teach you properly, what about your infrastructure? So this is a system. This is a process indicator. And next one is, this indicator measures things like design, system development and functioning or implementing. And next indicator is outcome indicator. What is that? Whether a program is achieving the desired result. We are delivering lectures, we are taking classes, theoretical classes, practical classes. What for? To help you to gain knowledge, to acquire skills. Okay. At the end of the session, that means once result will be published, how many percentage of students have passed in which division, or by securing what percentage of marks, that is outcome indicators. Is it clear? So in order to assess, hello, please keep silent. If you think the class is not required for you, please go, you can go. I do not have any objection. Okay, attendance is over. Everything should have some limitations. You are crossing your limit. Very many times I have told you. These things will come in the examination. What you will do then? Okay. So there are two types of indicators. One is process indicator, then is system. Whether the system is accurate or not, or correct is not. In evaluation, that is the procedure. And second one is outcome indicator. What is that? Yes, whether the program is achieving the desired change that we want. That means we want at the end of this course at least 95%. That is arbitrarily 90. Our goal 90, at least 95 or 99% students will pass. Out of that, 60 or 70% students will pass in first divisions or securing 70 or 80% marks. These are the outcome indicators. So once your results will be published, we can see how far our program, that means this one, process indicator, is accurate or not. In any program, in health education or health promotion program, that is there. Now this is very important, how to assess. This one, is it visible? ওখানে দেখতে পাবে না বলে আমি বলেছিলাম কাছে এসো, দেখতে পাচ্ছো? Is it visible? Can you visualize what is written? দেখতে পাচ্ছো? পাবে না, তার জন্য বলেছিলাম বাবা এদিকে আয়। This is very important. Now you cannot understand. You can pass, but whenever you go for service in WHO, very many times I am telling, in WHO or UNICEF as a program manager, everything, these things you have to do. You can act as a program evaluator. Then you will think what wrong you have did. Okay, evaluation questions that I told you. Type of program activity, what type of activity you have to undertake. What about your outputs and what about your process indicators? Number one, evaluation questions. Say for example, you are going, lot of money you have taken from WHO. Okay, for promotion of, say for example, one program for promotion of breastfeeding, Okay, to assess or to evaluate the program, you have to frame evaluation questions. Just one question. I am giving examples. What is the question? Have we implemented the program as planned? First you have to plan the program, then implement it. Then question comes about evaluation. We have to evaluate the impact or process of both, process and outcome. So the step 4, have you implemented the program as planned? For that reason, you have to determine the question. The question is that, have we implemented the program as planned? Now, to answer the question, we have organized activity. What type of activity we have organized to promote breastfeeding in the community? Okay. Program activity was number 1, to promote breastfeeding program, hold breastfeeding coalition meeting. We have planned to hold coalition meeting with whom? With the mothers, with the caregivers. We have to hold meeting. Okay. What are the process indicators? Number of meetings held. আমাদেরকে অনেক মিটিং করতে হবে। That is the process indicator. Now, what was the output? 12 breastfeeding coalition meeting by the end of this year. কি করতে হবে? What we have to do? We have to organize meeting. With whom? With the mother, even with the would-be mothers, with their grandmothers, with caregivers. Okay. To promote breastfeeding. So, number of meetings held. How many? Again, quantify. 12 breastfeeding coalition meeting by the end of the year. Okay. Meeting. Number one activity. What is the second activity? Develop and disseminate promotional posters. Okay. We have developed the posters. We have to disseminate the posters in approach areas. Okay. Number of posters created. How many? 5 unique posters of breastfeeding created within 6 months, encouraging breastfeeding. Next, number of posters distributed. First, we have to develop it, we have to distribute it, we have developed, we have distributed. How many we have distributed? 500 copies of 5 different unique or attractable posters distributed to the work sites in our community within 6 months. Okay. Next activity was produce guidelines on developing breastfeeding friendly policies for work sites. Number of guidelines created. One guideline resource document created for work site within 6 months on developing breastfeeding friendly policies. And last one, conduct advocacy meeting with the planners and policy makers. Okay. Number of meetings held with the planners and policy makers in your community. 2 meetings held with members of parliament, members of provisional parliament. Here we can say members of parliament, MLA, okay, panchayat members in our community by end of the year related to breastfeeding friendly policies. So, in order to promote breastfeeding, we have implement the program, and to assess the evaluability or to assess the effectiveness of the program, we have framed so many questions. Okay, these are the program activity and these are the outcome and process indicators. Is it clear? Is it clear? So we have to do that. Then develop action plan or develop evaluation plan for action. An evaluation plan is a written document. It details how you will monitor and evaluate your program and use evaluation results for program movement and decision making. That is about the evaluation plan. Number one is a written document, and then in this plan, evaluation plan, the things that will be highlighted, that is how you will monitor it, how you will evaluate the program, and how you can utilize the results of this evaluation program for future development or future activity that will be undertaken for improvement of the health of the community. How do you do? Number one, create an evaluation plan by building on information. Create an evaluation data collection matrix and finalize your budget. Then start data collection. Evaluation plan, then you have to start collecting information. To prepare a data collection, evaluation data, you will specify procedures, pilot state data collection tools, and train data collectors. This step also includes implementing the data collection plan. This one, develop data collection procedures. How you will collect data, train data collectors, because you see it is not possible for you people to collect data alone. So you have to train your data collectors who will collect data from all the stakeholders. Pilot procedures and tools. What are the tools of data collection? I am telling data collection, data collection. It has already been discussed. May not by me, but by other faculty member, tools of data collection. Bolo. You have collected data. In all the projects you have collected data already. So what are the tools? Key tool use korecho? What tool you have used to collect data? Questionnaire. The questionnaire is a tool. Schedule is a tool. Questionnaire is a tool. And collect data. Then once data will be collected, then next step is process the data and analyze the results. Definitely is a technical step. Okay. It requires the help of the statisticians. Okay. This is a technical step that involves engaging with the data, that is synthesizing and interpreting information from all sources. Your data analysis techniques will depend on number one, your evaluation question. If the question is okay, then it will be right. The type of data that you have collected, whether qualitative data or quantitative data or both, the resources available to support your data analysis. These steps allow you to make sense of the data collected and help answer the evaluation question. Once you have completed your analysis, start thinking about how to present it among your stakeholders. That is the final step. Enter the data, organize your data, what the data has. Interpretation. What is the interpretation and dissemination? Interpretation means try to find out the meaning of the data that you have collected. That is called interpretation. And dissemination means nothing but you have to present the data. To whom? To the beneficiaries. At the same time, not only the beneficiaries, to the planners and policy makers for the furtherance of the program, for the improvement of this program. Dissemination is making information available and usable to various audience, to various channels or formats. In order to do this step, what you require? Number one, interpret the data, develop recommendations, develop a communication strategy, and next one is create and distribute communication materials, communication products. Then only it is possible to improve your program effectiveness. And last one is apply evaluation results. What for? For the benefit of the community. Now we have come to the final step using your evaluation results. In this step, we are focusing on actually using the results to direct change and new thinking. Okay. Last conclusion. What I have told, this is the summary or conclusion. What to do? Evaluation helps organization to justify. Amra taka niyechi. We have taken money from the sponsorer. Is it so? So you have to justify that yes, this is fruitful. You have to justify, you have to support and improve programs and make other important decisions about them. To do that, what we have to do? Number one, clarify the program, forget about that. Most important thing, you have to engage the stakeholders. Who are the stakeholders? Now can I ask questions to you? Just repetition, nothing but what I have discussed. Who are the stakeholders? Simply in one word, stakeholders are beneficiaries. Okay? Maybe an individual, maybe an organization, maybe the whole community who are directly or indirectly benefited from this program. You have to engage them. If you do not engage them, how you can evaluate the impact of your program? You have to engage them. That means you have to ask questions to them. You have to collect data from them. Once they say yes, it is okay, they have benefited, then automatically your program is successful. Select evaluation questions. The selection of questions, that means selection of questionnaires, preparation of question is very important. If it is wrong, data will be wrong. So select evaluation questions that are both salient to those who take action and relevant to the program in its current context. Okay, that is over. Selection of question is okay. Then number one, what methods you will follow, what methods you will use to collect data that will yield correct or right results. Then method you have to follow. Say for example, examination. What type of method examination, university follow to assess the effectiveness of this process, the teaching, training procedures. Likewise, choose methods that will yield accurate data. Then, once data will be collected, you have to analyze the data with great care. If analysis is wrong, everything will be wrong. Data collection is wrong, everything will be wrong. Then framing of question is wrong, then everything will be wrong again. Okay, and share what you have learned. You have to share it with the stakeholders, with the policymakers, with the planners, with the politicians who can take the decisions. Then only fund will generate. Again, fund will generate. Your employment will be in guarantee. All of this will support the best use of evaluation findings. So proper evaluation definitely will take time and resources, but yield valuable results. Taken step by step, anyone can complete a well-designed evaluation, one that encourages beneficial action to follow. So that's all about steps of evaluation of any program. Whatever may be health education program, it may be health promotional program, it may be in examinations, it may be in course program. So the steps are same. Can anybody reiterate the steps of evaluation one by one? How many steps? How many steps are there? 10 steps. What is the first step? What is the last step? First step is clarifying the program. And last step is now after that. Interpretation 9 steps. Okay. Sharing the evaluation results. Before that interpretation, before that analysis, then process, then again उल्टे बोलते हैं process, analyze, data collection, evaluation plan, determine procedures, determine evaluation questions, then assess the resources. Before that, engage the stakeholders, and first one is clarify the program. Again, first one is মনে রাখার চেষ্টা করো, clarify the program. Second one is engage stakeholders. Third one is assess resources and availability. Fourth one is frame or determine evaluation questions. Next one is determine the procedures or techniques of data collection. Then plan karo now, evaluation plan, determine or develop evaluation plan. That is the planning part. Once planning part will be over, then start implementation. Planning, implementation, then utilization. These 3 classes. Planning over. Then next data collection. Data collection next. Processing of data, analysis of data, processing analysis. Okay. Next to interpretation of the data. Then after interpretation, dissemination of information and utilization of your findings. So that is the 10 steps of program evaluation. মনে থাকবে? পরীক্ষা এলে পারবে তো? কত নম্বর কোশ্চেন থাকতে পারে? 5। তো 10টা স্টেপ লিখতেই হবে, otherwise you cannot expect 5 marks.
Mesenteric cyst. Today's topic, there are 2 topics, retroperitoneal tumor and mesenteric cyst. Mesentery, few people will remember the anatomy, many are like me, I won't remember the anatomy most of the time maybe. So mesentery is that which holds the intestinal loops to the posterior wall of the abdomen. Okay, there is a mesentery. What is omentum? Omentum is it's wrapping from the stomach down. and then it goes behind. There is a lesser sac, there is a pancreas behind, retroperitoneal structure. But omentum is এটা intestinal loop. যদি আমরা transverse section করি, there is something that is holding the peritoneal loops to the abdominal wall. ঠিক আছে? These are the spine, this is the vertebral column. এই যে loops গুলো covering আছে, which is holding, this is the mesentery. It is separate from the peritoneal covering, it is separate from omentum, and the peritoneal mesenteric folds which is holding the intestine, that is unique by itself, and it is attached to the abdominal wall like this. Line of feeds. You remember? Line of feeds, attachment line of feeds. ওখান থেকে সেকেন্ড পার্ট থেকে নিয়ে ইলিউসিক্যাল জাংশন অব্দি mesenteric line of attachment, that is line of feeds. এই যে লাইন অফ ফিডস, লাইন অফ ফিডস এর ওই mesenteric ফোল্ডটা ওখানেই থাকে, সব ইন্টেস্টাইনাল লুপস গুলো অ্যাটাচ থাকে, and তার মধ্যে ওই mesentery যদি cyst হয়, swellings থাকে, it can be unilocular, it can be multilocular, and there are stages কিভাবে cyst গুলো ছোট থাকলে গ্রেড করা আছে, ক্লাসিফিকেশন আছে. You don't have to go into such details, but you should know what is mesenteric cyst. Mesenteric cysts are usually mainly lymphocytic or enterogenous. It can be dermoid cyst, but differential diagnosis is important because lymph node masses of tuberculosis, they mimic like cyst. If there is a hydrated cyst of mesentery, it will look like the mesenteric cyst. But mesenteric cysts by themselves are usually lymphocytic. If the lymphatic channels are not well developed, they say there is some blockages in the mesentery, then the cyst develop, lymphocytic mesenteric cyst. But the complications occur if there is a twist, torsion, if there is a hemorrhage, if there is a trauma, if there is an infection, the complications will arise. But that's separate. How does it present? কি করে তোমার কাছে পেশেন্ট আসবে? Usually lymphocytic cyst যদি infection না হয়, patient come only very late if they become big, especially in children. Less than 15 years, patient with pain abdomen around umbilicus will come to you. If the cysts are causing a pressure change in the surrounding organs, there is a bilious vomit, there is pain in the abdomen, there is indigestion, there can be loose motion, because these lumps or these cysts may cause obstruction. They may cause volvulus of the intestine, because the intestine may roll up. একটা স্টেজে পর বড় হচ্ছে বড় সিস্টটা টুইস্ট করে দিল, ভলভুলাস হয়ে গেল। ভলভুলাস মানে কি? ইন্টেস্টাইন যখন পেঁচিয়ে যায় নিজেদের মধ্যে, ওটাকে ভলভুলাস বলে। ইন্টারসেপশন, একটা ইন্টেস্টাইনাল লুপ আরেকটার ভেতরে ঢুকে গেল, দ্যাট ইজ ইন্টারসেপশন। তো ইন্টারসেপশন হয় না, ভলভুলাস, হ্যামারেজ, ট্রমা, ইনফেকশন, এই সব জিনিসগুলো এই সিস্টের জন্য হয়। দিস আর দ্য কমপ্লিকেশনস, অ্যান্ড ইউজুয়ালি সেগুলোও হয় না, পেন অ্যাবডোমেন হয় যদি ইনফেকশন হয়, যদি একটু বেশি বড় হয়ে ইনফেকশন অবস্ট্রাকশন করলো অ্যাবডোমিনাল ওয়াল, পেন, তখন বাচ্চারা আসে। ইউজুয়ালি 1500 something, 1500 to বার্নিনি বলে কোনো সায়েন্টিস্ট, he performed a autopsy on an 8-year-old child. তখন first it was diagnosed. 1500 say, it is something separate. It is something totally different from the other swelling cyst tumors of the abdomen, mesenteric cyst. But it was slowly and slowly burning এর পরে অনেকগুলো সায়েন্টিস্ট আসলে Tilak's latest 1900 something he diagnosed this mesenteric cyst as some characters very unique to itself. ইউনিক ক্যারেক্টার্স বলতে ও বললো যে বাচ্চারা আসে পেন অ্যাবডোমেন হয় ভমিটিং থাকলে থাকে বাট দিস সোয়েলিংস আর ভেরি সেপারেট ফ্রম দ্য আদার অ্যাবডোমিনাল সোয়েলিংস হাউ ওটাকে বলে টিলাক্স ট্রায়াড ওকে তো আমরা কজেস এর মধ্যে বললাম ওটা আরো ডিটেলসে যাব ওটা এন্টেরোজেনাস লিম্ফোসাইটিক ডার্মোয়েড ওই সবগুলো তো differential diagnosis এর মধ্যে আসলে complications we have discussed complications pain হচ্ছে লুজ মোশন হচ্ছে ভমিটিং অ্যানোরেক্সিয়া all that জন্ডিস হয় না লুজ মোশন হতে পারে ডিফারেনশিয়াল ডায়াগনোসিস ইনভেস্টিগেশনস পরে আসছি ডিফারেনশিয়াল ডায়াগনোসিসে করার আগে ফার্স্টে ক্লিনিক্যাল এক্সামিনেশন অফ দ্য অ্যাবডোমেন ক্লিনিক্যাল অ্যাবডোমিনাল এক্সামিনেশনের সময় যখন আসছে usually these cysts mesenteric cysts বা retroperitoneal tumors until they become very big বা cause any complication they don't come to you, doctors don't even know, the patients don't complain and they don't come. Now when you examine the patient he will have said the pain, this pain pulse is usually regular, patient doesn't have jaundice, no fever usually until there is an infection. Sorry. This swelling will be cystic. Cyst examination of a abdominal mass. Cyst examination শিখিয়েছি hydrocele examination কতজনে পারে? Do you know how to examine? What's the fluctuant swelling? What's the fluctuant? What is the non-fluctuant? What is the dull swelling? What is the resonant swelling? তোমাকে শেখানো হয়েছে তুমি হাইড্রোসেল দেখোনি ওপিডিতে পেশেন্ট এক্সামিনেশন কি করেনি হাইড্রোসেল রেজ আপ ইওর হ্যান্ডস প্লিজ হাইড্রোসেল দেখোনি তো প্লিজ কাম ওভার আমি কালকেও আছি ওপিডিতে পরশু আছি whenever you want a special class you tell me but these are the basic things which will be difficult for you to take up when you are in a final year because there are so many subjects which are very important, all are very important. Ophthalmology, gynae, everybody will say, look at me, leave surgery behind. The fluctuant swelling is when you press on one end with two hands, keeping one swelling steady, there will be, you will feel a impulse on the other side. That's fluctuant. In depression, the depression occurs and you feel an impulse in the other hand. এই হাতে যদি স্টেডি করে রাখো সোয়েলিংটা আর এখানটা টেপো যেমনি বেলুনে ইটস আ ফ্লাকচুয়েন্ট ওটাকে যদি মারো একটা রেজোনেন্ট বুঝতে পারছো কিন্তু কাটকে দিস ইজ ডাল সোয়েলিং দিস ইজ ডাল হোয়াট ইজ রেজোনেন্ট যেটাতে একটা হলো সোয়েলিং হলে ওটা রেজোনেন্ট ওকে এই mesenteric swellingটা কি হয় on clinical examination you will find কে abdomen surgical examination করতে পারে abdominal examination clinically কেউ পারো না fine but this is very important for a doctor to examine to know how to examine the abdomen এখনই সবাই লাইন দিচ্ছে তুই তো ডাক্তার হচ্ছিস তুই পেটে ব্যথা হচ্ছে তুই দেখে দে তোমরা তো পেট এক্সামিন বাড়িতে অহরহ করছো মায়ের বাবার কাকার পিসির তাই না সো ইউ হ্যাভ টু go through your books clinical surgery please its books are by Makhanlal Shah Dr. Makhanlal Shah is practicing in Kolkata it's acclaimed all over the world as bedside surgical very good book SRB clinics are there surgical clinics go through that and buy the book of Bailey Love for surgery just start your from the launching pad to start studying I'll be there to help you whatever little help I can I'm not a great surgeon I will not say myself but you have to know how to examine a patient of the pain abdomen. Central abdomen, সবসময় পেটটাকে আঁকা হয়, এটা তো রাব হচ্ছে না, হ্যালো? The patient, when you make him lie down, সবসময় examine the patient from the right side of bedside. Right side না হয় তুমি যদি left side এ মাথা থেকে পেট দেখো না, you will be asked to get out of the room. Nobody will ask you to stay back for your exams. They will say just come after 6 months or 1 year. Understand? So that is how important it is to examine properly abdominal pain. Understand? Stand on the right side of the patient. Examine the pulse. Go through the lymph nodes. Go through the other pulses of the body. Then ask the patient to fold the legs. Then quadrants of the abdomen are important to know. Quadrants are this one is right hypochondrium, left hypochondrium. This is iliac fossa. This is a right iliac fossa. This is hypogastrium. This is umbilical region. This is right flank. This is left flank. 9 quadrants. This is the imaginary line from the mid-clavicular region. And these are the lines from the costal and the pelvic region. So you divide the abdomen in 9 parts. And every part has got an organ which is very important. Not one organ, but several organs. So that is how you come to a diagnosis. Okay? So when a patient with mesenteric cyst, a boy has come to you, 10-year-old, with pain abdomen, you will find the swelling is near the umbilicus or like this. Swelling is here because it is rising from the mesentery. The mesentery is here. The root of the mesentery is here. It's 6 centimeter long root. তারপরে এটা খুলে যায়, ওটার মধ্যে সব intestinal loops গুলো আছে. Okay? So mesenteryর মধ্যেই যখন lumpটা বড় হয়ে গেছে, it is like this. You will find that this is the line of attachment, line of threads. When you examine, it is a resonant cystic mass. Cystic mass. Cystic mass কেমন? গোল মতন you feel when you examine pain abdomen নিয়ে lump নিয়ে abdomen আসে. Lump abdomen is a long case, it's a short case as well. তোমাদের দেখবে পরীক্ষায় আসবে short case, long case, spot detection. তো এইগুলো lump abdomen you have to examine. যেই lumpটা চারিপাশ ধরে you can define the border, define the সব lump যে তোমার বড় আসবে তা নয়, কোনোটা ছোট কোনোটা বড়. অ্যাপেন্ডিকুলার lump অন্য রকম, gallbladder lump আলাদা রকম, right hypochondrium gallbladder lump, Murphy's sign positive আসে যখন acute cholecystitis হয়. তো এগুলো ডিফারেনশিয়াল ডায়াগনোসিস. ওই লাম্পটা কিসের লাম্প? এই লাম্পটা দেখবে সেটা সিস্টিক, band of resonance all around, and it moves in the direction perpendicular to the line of attachment of the mesentery. It moves perpendicular. এমনি মুভ করছে, এমনি মুভ করছে না, বা সাইড টু সাইডে যাচ্ছে না. রাইট অ্যাঙ্গেল টু দ্য লাইন অফ অ্যাটাচমেন্ট কেমনি এমনি. তো এটা হচ্ছে পারপেন্ডিকুলার লাইন, ইট ইজ মুভিং ইন দিস ডাইরেকশন. যেই লাম্পগুলো ভার্টিক্যালি মুভ করছে সেগুলো সেপারেট. রিনাল লাম্পস গুলো পেছন দিকে সরে যায়, এই লাম্পটা পেছনে সরবে না. এই লাম্পটা সাইড টু সাইড হবে না, গলব্লাডার লাম্প গুলো সাইড টু সাইড হয়. শুধু প্যানক্রিয়াটিক সিস্ট গুলো সেগুলো ট্রি লাইক হয়, ট্রি লাইক অ্যাটাচমেন্ট. প্রথম দিকে উপরের দিকে উঠবে, তারপর সাইড টু সাইড. সব লাম্পে আলাদা করে ডিফারেন্সিয়েট করা যায় কে কিরকম লাম্প. ডায়াগনোসিসটা তুমি ক্লিনিক্যাল, আজকাল কেন লোকেরা ক্লিনিক্যালি ভালো নয়, বিকজ সিটি স্ক্যান, পেট স্ক্যান, এমআরআই, আজকে সকালেও গাদা পড়েছো তোমরা, কতগুলো রেডিও ডায়াগনোসিস পড়েছো সার্জিক্যাল, সেই জন্য ক্লিনিক্যালি আর কেউ ভালো হয় না. কিন্তু ক্লিনিক্যালি যে মানুষটা ভালো সে কিন্তু সবচেয়ে ভালো ডাক্তার হতে পারে. তার প্রচার প্রসার হয়নি, বাট হি নোজ হিজ সাবজেক্ট ওয়েল, he or she knows the subject well. So you should be able to know your clinical examination. This is known as Tilak's Strad. Tilak's Strad. It moves right angle to the line of attachment. It is cystic with a resonant bag and it is fluctuant in nature. এটাকে টিলাক্স ডাক্তার যে ছিলেন উনি বার করেছিলেন। ওকে, তো ইনভেস্টিগেশনসে আমরা পেলে ব্লাড এক্সামিনেশন যদি করি HBTC-DC will be okay if the patient doesn't has much infection or hemorrhage or trauma or it's not a tubercular or a hydrated cyst. Blood test will be okay. Elective liver function test will be okay. Urea creatinine will be okay. ঠিক আছে, এবারে আল্ট্রাসাউন্ড ডায়াগনোসিসে দে উইল শো ইউ দেয়ার ইজ আ সিস্ট। ফিমেলসে তাও ডিফারেন্সিয়াল ডায়াগনোসিস করতে অসুবিধা হয়, বিকজ ওভেরিয়ান সিস্ট যদি বড় হয় সেটা কিন্তু পেলভিস থেকে রাইজ করে ওখানে চলে গেলে তো মনে হবে ওভেরিয়ান সিস্ট। যদি ওটা কিডনিটা বড় হয়ে গিয়ে থাকে হাইড্রোনেফ্রোসিস, ওটাও ডিফারেন্সিয়াল ডায়াগনোসিসে গেলে কিডনিটা বড় হয়ে গেছে, স্টোন আটকে গেছে, দ্য কিডনি হ্যাজ ব্লোটেড আপ লাইক এ বালুন। There can be a urinary bladder, ওখানে যদি কোনো ডাইভার্টিকুলাম থাকে, ইউরিনারি ব্লাডার ডাইভার্টিকুলাম কাকে বলে? এই যে ব্লাডার, এই যে ইউরেটাস, এটার মধ্যে ডাইভার্টিকুলাম এমনি এমনি করে হয়। ইউরেটাস না, এটা ইউরিনারি ব্লাডারের ওয়ালের মধ্যে থেকে থিনড আউট মাসল টিস্যু থেকে মিউকোজাটা ভেতরে চলে গেল, নিয়ে ডাইভার্টিকুলাম তৈরি হয়ে গেল। ডাইভার্টিকুলাম তবুও এটা কিন্তু ইউজুয়ালি তুমি পাবে ডিফারেন্সিয়াল ডায়াগনোসিস। কিন্তু রেমানেন্টস অফ ইউরাকাস এন্ড অল দ্য ইউরিনারি রেমানেন্টসে ওটাও কিন্তু ডিফারেন্সিয়াল ডায়াগনোসিসে আসে, ডিফারেন্সিয়াল ডায়াগনোসিসে আছে। ওকে, তো ডিফারেন্সিয়াল ডায়াগনোসিস তোমার ইনভেস্টিগেশনে অল দ্য ব্লাড টেস্ট, অল ইউর ইউরিন টেস্ট, অল ইউর আল্ট্রাসাউন্ড, তারপরে সিটি স্ক্যান, যদি তারপরেও কনফার্ম না হতে পারে দেন ডু আ সিটি স্ক্যান, তারপরে ইউ ডু দ্য ট্রিটমেন্ট। হোয়াট ট্রিটমেন্ট উইল ইউ ডু? ইউজুয়ালি ইট ইজ জাস্ট ইনইকুলিয়েশন। আচ্ছা, ইট ডিপেন্ডস অন দ্য টাইপ অফ দ্য সিস্ট। যদি একটা কাইলো লিম্ফ্যাটিক সিস্ট থাকে ইউজুয়ালি ইট হ্যাজ আ ইন্ডিপেন্ডেন্ট ব্লাড সাপ্লাই। এটা ইন্টেস্টাইনাল ওয়াল, সিস্টটা এখানে আছে, ইন্ডিপেন্ডেন্ট ব্লাড সাপ্লাই, ল্যাপারোটমি করে খুলে ওটা আলাদা করে ইনইকুলেট করলে বেরিয়ে যায়। যদি খুব বড় সিস্ট হয় মার্সুপিয়ালাইজেশন করতে হয়। মার্সুপিয়ালস কারা হয়? ক্যাঙ্গারুজ। কেন কি ওদের ওটাকে স্যাক মতন আছে মার্সুপিয়ালস, তো সেটাই ওই স্যাকটাকে খুলে দাও and stitch করে দাও সাইডে সাইডে। যদি খুব বড় সিস্ট and it's difficult, you cannot shell it out, you cannot move it, you cannot remove it totally, bits and pieces এ বেরিয়ে আসে, কিন্তু ওর ভেতরের পোর্শনটাকে নষ্ট করে দিতে হয় উইথ আইদার প্রভিডন আয়োডিন দিয়ে টাচ করে দাও বা কিছু একটু কটরি করে দাও, ইলেকট্রো কটরি করে নষ্ট করে দাও ভেতর, সো দ্যাট there is no recurrence. What is recurrence? আবার থেকে বার করে দিলে আবার থেকে তৈরি হয়ে গেল, সম্ভাবনা হয়, there is a chance of recurrence. এমনিতে ইনসিডেন্স খুব কম, it's very very low. Incidence is low, it's in younger children, it's in adolescent phase, very rarely in the adults, and you need to operate only when the patient comes to you with pain abdomen, some complications are there, you cannot come to a different diagnosis, then you operate. আচ্ছা, কখনো কখনো এই সিস্টটা কিন্তু ডুপ্লিকেশন of the bowel বলের ডুপ্লিকেশন থেকে হয়ে যায়। এই যে বাবল বলের এটা হচ্ছে মিজেন্ট্রিক বর্ডার, এটা মিজেন্ট্রিক, এখান থেকে যদি ডুপ্লিকেশন হয় সিস্ট তৈরি হয় তাহলে কমন ব্লাড ভেসেল থাকবে, কমন ব্লাড সাপ্লাই থাকবে। ডুপ্লিকেশন যদি হয়, ডুপ্লিকেশন মানে কেন? ডুপ্লিকেশন মানে কি, বাবল বলটা তৈরি হচ্ছিল এমব্রায়োলজিক্যালি, যখন ওটা তৈরি হচ্ছে there is some duplication of the cyst, ওটা নিজে wall off হয়ে গেছে কমন ব্লাড সাপ্লাই নিয়ে। এবারে ওর কমপ্লিকেশন হলে ইউ হ্যাভ টু কাট অফ দ্য এন্টায়ার ওই পোর্শন অফ বাবল অ্যাজ ওয়েল, রিসেকশন অ্যান্ড অসমোসিস বলে। when you repair, you remove the whole cyst in toto with the bowel and you repair, mesenteric repair হবে আর bowel repair হবে। so that is the ওই enterogenous cyst এর সময় সম্ভাবনা হয় যে common blood supply আছে, then you have to resect out the blood cyst. Okay, so the treatment depends on that, and the recurrence যেন না হয় সেই জন্য দেখা হয়। mesenteric cysts are They don't turn into malignancy by themselves, but teratogenous chances 0.1%, 0.2%, 0.3%, somewhere is when it has been mentioned that teratogenous. Otherwise, usually they are very benign. Urogenital remnant নিয়ে আমরা কথা বলছিলাম, এই যে এখানটায় আছে teratomas dermatosis. These are the differential diagnosis, traumatic tuberculosis. Okay, একটু বাড়িয়ে দাও। কিন্তু আমি যতটুকু বললাম, it was easy to understand, mesothelium layer ভেতরটা থাকে, and usually they don't turn malignancy. So tubercular abscess, differential diagnosis বললাম, tubercular cold abscess, কারণ কি lymph nodes তো থাকে mesentery-তে, if you are having tuberculosis, patient has lymph nodes, there will be multiple lymph nodes in mesentery. You shall it or we send for biopsy. অনেকবার হয়েছে আমার সঙ্গে যে obstruction হয়েছে, আমি pathology খুঁজে পাইনি, ultrasound was not there, very prevalent in my times, but whatever was done, we found those lymph nodes, caseation masses, caseating lymph nodes. We have done biopsy, we have done, many times you have to do resection and osmosis. খারাপ হয়ে গেছে, সিস্ট গুলো বড় হয়ে গেছে, টুইস্ট করে গেছে, একদম টুইস্টেড করে বাউল নেক্রোসিস হয়ে গেছে, ইস্কেমিয়া হয়ে গেছে। বাট যারা ইম্পেন্ডিং নেক্রোসিস, সেগুলোকে সেভ করা গেছে। ইম্পেন্ডিং নেক্রোসিস মানে পেন অ্যাবডোমেন, সিভিয়ার ইস্কেমিয়া, ইস্কেমিয়া মানে ব্লাড সাপ্লাইটা কম হচ্ছে ওখানে, ইস্কেমিয়া, ইস্কেমিক চেঞ্জেস, তো সেগুলোকে সেভ করা গেছে। আনটুইস্টিং করে আমরা গরম প্যাডস দিয়ে দিয়ে চাপ দিয়ে দিয়ে রেখেছি, যখন পেশেন্টের আনটুইস্ট হয়ে গেলে পেশেন্টের সার্কুলেশন হয়ে গেলে ভালো হয়ে যাবে। ওকে, স্মল বাউলসেই বেশি হয় 60%, কলোনিতে 40%, মিজোথিলিয়াম এটাকে নন নিউপ্লাস্টিক মিজোথিলিয়াল সিস্টও বলা হয়। দ্যাটস অলরাইট। Small bowels, the usual site is ileocecal region কাছাকাছি, will be, that is enterogenous, and really thick volts, but the treatment will be same. Patients complication complaints with on admission will be the same, and you can enucleate it or you have to resect it. Enucleation, what is enucleation? You shell it out. Okay, what is marsupialization? You open it out, marsupialize, and so you sew the edges of the cyst wall to the mesentery. Okay, surrounding structures. Okay, and what is the dissection anastomosis? When there is a common blood supply, you separate it out and separate out along with the bowel portion where it has this common blood supply. Take out the cyst, repair. And how do you, what is the post-operative treatment? Nil orally, IV fluids, symptomatic supportive drugs, antibiotics. Metrogel is most needed. Patient will come up within 7 days. You remove the stitches and then patient can go. What is the other latest method of treatment? You do laparoscopic, diagnostic laparoscopy to find out the cause. কি হয়েছে? আল্ট্রাসাউন্ডে ভালো করে বোঝা যাচ্ছে না, ওটা হাইড্রোনেফ্রোসিস না, ওভেরিয়ান সিস্ট না, ওটা রেট্রোপেরিটোনিয়াল টিউমার মাস না, ওটা ইউরোথিলিওমা না, ইউরোমা না, এটা কোথাকারের কি। সো ডিও ডায়াগনস্টিক ল্যাপারোটমি, ল্যাপারোস্কোপি, ডায়াগনস্টিক ল্যাপারোস্কোপি পরে ফাইন্ড আউট না এটা মিজেন্ট্রি থেকে হয়েছে। ওকে, তাহলে আমরা উইল মেক মোর পোর্টস। হোয়াট ইজ মেকিং পোর্ট? What is making a port? Laparoscopically, when you do a diagnostic laparoscopy, you do it with through the umbilicus. Okay, the umbilicus, say single port cells, single laparoscopic port. You view the whole abdomen underneath the light on TV screen, of course. And if you find out the reason of your pain abdomen complaint is because of mesentery, you make further more ports. Introduce your lap applicators, scissors, cautery, electrocautery, Maryland forceps. You separate it out and you puncture it, you aspirate it, aspiration, ওগুলো সব টিউবস লাইক থাকে। তুমি দেখেছো ল্যাপারোস্কোপিক সার্জারি? তুমি দেখেছো তো ল্যাপারোস্কোপিক সার্জারি গুলো ইউটিউবে দেখে নিও, মাঝে মধ্যে মুভি টুভি তো দেখতে থাকো, তো দেখেছো তো ওটা কটরি দিয়ে করে লিগাশিয়াস দিয়ে লিগা ক্লিপস দিয়ে অ্যাপ্লাই করে and we take it out. So that is the latest mode of treating a mesenteric cyst. এটা টিলাক্স স্ট্রাইড যেটা বলছিলাম সেগুলো সব বলা আছে, ওকে? এগুলো হচ্ছে ডিফারেন্সিয়াল ডায়াগনোসিস। এটা অনেক বেশি আছে, এখানে মাত্র 4টে লেখা আছে, বাট দিস আর, এবার তুমি হ্যাঁ ওষে চলে যাবে Retroperitoneal tumor mass. তাহলে mesenteric cyst এবারে ছাড়তে পারি। Can we stop at it? Can have you understood? কিছুটা বুঝেছো? তোমরা যখন পেন অ্যাবডোমেন, আমি আউটডোরে আমি পেশেন্ট দেখাবো হাউ টু এক্সামিন আ পেশেন্ট অফ পেন অ্যাবডোমেন, তখন আমি দেখিয়ে দেবো টিলাক্স স্ট্রাইড হলে কোনটা, সোয়েলিং অ্যাবডোমেন কি করে দেখতে হয়, যে কোনো সিস্টিক নন সিস্টিক সোয়েলিং কি করে দেখতে হয়, এগুলো ভীষণ ইম্পর্টেন্ট হাউ টু এক্সামিন পেশেন্ট ক্লিনিক্যালি। এই জন্য ক্লিনিক্স আমরা কিছুটা ডিসকাস করলাম, অপারেশন কিছুটা ডিসকাস করলাম, বাট অপারেটিভ বুঝতে কোনো কোথাও অসুবিধা নেই, মনে থাকবে। এটার মধ্যে মোস্ট ইম্পর্টেন্ট টিলাক্স স্ট্রাইড, মোস্ট ইম্পর্টেন্ট দু রকমের ইম্পর্টেন্ট, কার্ডিওলিম্ফ্যাটিক অ্যান্ড এন্টেরোজেনাস। ডিফারেন্সিয়াল ডায়াগনোসিস এর ডার্ময়েড সিস্ট, হেটেরোজেনাস খুব কম হয়। টিউবারকুলোসিস, হাইড্রাইটিস সিস্ট এগুলো মনে থাকবে আশা করি। ফ্লুইড যদি থাকে অ্যাসাইটিস থাকবে। কমপ্লিকেশনে হ্যামরেজ, টুইস্টিং, এইসব ট্রমা, ইনফেকশন এগুলো মনে থাকবে আশা করি। ক্লিনিক্যাল এক্সামিনেশনে লাম্প ইন দ্য অ্যাবডোমেন, সেন্ট্রাল অ্যাবডোমেন, টিলাক্স স্ট্রাইডটা মনে থাকবে আশা করি। সো at treatment shelling out is easy. If it is difficult, marsupialize. If it is still difficult, dissection also. এই কটা জিনিস মনে থাকবে। That completes 20 number mark long question on mesenteric cyst. Done? Easy? Unforgettable? Okay, we have got very tough জিনিস, retroperitoneal tumors. তার আগে retroperitoneal organs কি আমরা একবার দেখে নেব? what are retroperitoneal organs? ওটা কি রিভাইজ করে নেব? কে কে চাইছে retroperitoneal organs রিভিশন একবার? সবাই ঘুমিয়ে পড়েছে কি? গন? retroperitoneal organsটা একটু দাও, এটা দরকার নেই। retroperitoneal organs, হ্যাঁ এটার মধ্যে, হ্যাঁ হোল্ড প্যারাইটাল পেরিটোনিয়াম আছে, মিজেন্ট্রি আছে, ভিসরাল পেরিটোনিয়াম এন্ড পেরিটোনিয়াল ক্যাভিটি আছে। এই যে পেরিটোনিয়াল ক্যাভিটিটা, এইটা পেরিটোনিয়াল ক্যাভিটি, ওকে? এটা হচ্ছে মিজেন্ট্রি, ওকে? পার্ডন, দিস ইজ দ্য retroperitoneal স্পেস। এই যে পেরিটোনিয়ামের পরে যেটা আছে এটা হচ্ছে তোমার স্পাইন। নেক্সট, এইটা হলো তোমার প্যারাইটাল পেরিটোনিয়াম। তুমি যখন অ্যাবডোমেন আমরা দেখছি তখন এটা এই যে ইয়েলো লাইনটা হচ্ছে মিজেন্ট্রি, আমরা ওটা পড়ে নিলাম। এবারে এটা ভিসরাল পেরিটোনিয়াম, এই যে এই জায়গাটা পেরিটোনিয়াল ক্যাভিটি। নেক্সট এই জায়গাটা retroperitoneal স্পেস। নেক্সট retroperitoneal স্পেসটাকে ডিভাইড করা যায় ভার্টিক্যালি, সুপ্রারিনাল, রিনাল এন্ড posterior lower down, ওকে? ওরকম ভাবেও ডিভাইড করা যায় posterior peritoneum ক্যাভিটিটাকে, যে কিডনির ওপরের জায়গাটা খালি, যেটা কিডনির পাশে, যেটা কিডনির সাইডে। কেন কি ওখানে এত বেশি ইম্পর্টেন্ট স্ট্রাকচারস আছে যে কিছু বলার না। ওটা স্যাড পাকার বলে একটা সিনোনিম তো না, এটা অ্যান্টোনিম, হোয়াট ইজ দ্যাট ওয়ার্ড? মানে এটা স্যাড পাকার। S for suprarenal, adrenal, D for তোমার duodenum portion, second, third, fourth, P for pancreas, pancreas portion, ইউ ফর ইউরেটাস, ইউরিনারি ব্ল্যাডার পোর্শনটা, তারপরে ই আর, ই ইজ ইসোফেগাস, আর ইজ রেক্টাম। এইগুলো মেজর অর্গানস যেগুলো বলেছে সাইড পকেট, যেগুলো পেছনে থাকে, রেট্রোপেরিটোনিয়াল। আর প্রত্যেকটার থেকে ইম্পর্টেন্ট এক একটা মাস বেরোয়, আর প্রত্যেকটা টিউমার ইজ ইম্পর্টেন্ট। কিডনি থেকে বেলস টিউমার বেরিয়ে গেল, রেটিনোব্লাস্টোমা কোথা থেকে বেরিয়ে গেল, ফিওক্রোমোসাইটোমা সুপ্রারেনাস থেকে বেরিয়ে, এই ওয়ার্ডস গুলো পড়েছো তো নিশ্চয়ই। ফিওক্রোমোসাইটোমা, বেলস টিউমার, রেটিনোব্লাস্টোমা, lymphoma, Hodgkin's disease, and all of them demand hours of study. Hours and hours of study. Each one of them are very important. And যারা হজকিন্সে ভালো জানে তারা আবার লিম্ফোমাস মানে ওগুলোতে স্পেশালিস্ট, তারা কিন্তু ফিওক্রোমোসাইটোমাটা এন্ডোক্রাইনোলজিস্টকে দিয়ে দিয়েছে। এন্ডোক্রাইনোলজিস্ট উইল ডিল উইথ দ্যাট। দোজ হু আর গুড ইন নার্ভস, নিউরোসার্জারি করছে ওরা, they are dealing with all. Those who are dealing in orthopedics, they are dealing with only retroperitoneal muscles গুলো। কেন কি schwannoma, sarcoma, liposarcoma, all of them arise from retroperitoneal spaces and all. So in half an hour, in 20 minutes, do you expect me to complete all of these topics? It is not possible. But every one of them is very interesting. তাই নয় কি? Every one of them. Lipoma, leiomyosarcoma, leiomyoma, say, leiomyosarcoma, malignant. Sarcoma, sarcoma varieties. Retroperitoneal fibrosis নিজে এক একটা অর্গানকে এমন ভাবে জাঁকড়ে এক একটা লাম্প তৈরি করে না, মাথা খারাপ হয়ে যাবে। আমরা ল্যাপারোটমি করেছি যখন, তখন এমআরআই স্ক্যান ছিল না, পেট স্ক্যান ছিল না, and laparotomy we had to do, and the laparotomy was very big because retroperitoneal tumor masses come very late to you. If they are malignant, patient goes into stage 3, stage 4 malignancy before they come to you. Can they are slow growing? Usually they don't cause pain until they compress upon the nerves posteriorly. Pancreatic tumor, pancreatic cystadiomas, এগুলো যদি বড় বড় হতে থাকে তখন they will cause pain, they'll come to you. যখন হচ্ছে, তৈরি হচ্ছে, they won't tell you, people will not suffer, they will not come to you. Retroperitoneal tumors, আমরা যখন পড়েছি, it was a very small chapter. Now it is very important for you to know what is retroperitoneal tumors. They can arise from fats, adipose tissue, they can arise from nerves, they can arise from muscle layers, they can arise from all the important organs that we have discussed, which are behind the peritoneum. All the major organs of urinary bladder to ureter to kidneys to adrenals to your bones, even sarcoma, ওইগুলো সব কিন্তু এগুলোর মধ্যে ঢুকছে। And in 20 minutes, I don't know how it is possible. So today we will go through retroperitoneal spaces. You are seeing it is a very big thing, and একটু নিজেরাও পড়বে, তারপরে বলবে যে ম্যাডাম আপনার চেয়ে বেশি আমরা জানি, আমরা পড়ে এসেছি। নেক্সট ক্লাস উইল বি টেলিং মি দ্যাট। ওকে, একটু এরকম। এই যে বলছিলাম না, স্যাড পাকা, সুপ্রারেনাল গ্ল্যান্ডস, আয়োটা, আইভিসি, aorta, তোমার aorta and branches will lie to the little left, and তোমার IVC will be to the right. তো এটা ব্রাঞ্চ, কতগুলো ব্রাঞ্চেস আছে, কতগুলো আনব্রাঞ্চড আছে, কটা সিঙ্গেল পেয়ারে ব্লাড সাপ্লাই আছে, মেসেন্ট্রিক, ইনফিমেসেন্ট্রিক, সিলিয়াক ব্রাঞ্চ, তারপরে ডিভাইড হচ্ছে কটা, এগুলো সব কিছু জানতে হবে। এগুলো সবকিছু জানবে, ভালো করে অ্যানাটমি গুলো পড়বে, ব্লাড সাপ্লাই গুলো কোন কোন অর্গানস যাচ্ছে পড়বে, তাহলেই বুঝতে পারবে মেটাস্টেসিস কিভাবে হয়। মেটাস্টেসিস বুঝতে পারলে তখন তুমি লিম্ফোমাটাকে ভালো করে আয়ত্তে আনতে পারবে। ইট উইল বিকাম ইজি ফর ইউ ইফ ইউ গো থ্রু দিস ক্লাসেস অফ সার্জারি, then the difficult things will be very easy for you to understand. I'm taking this class in a very short method so that just to make you understand and make you remember, because you're studying surgery for the first time and you should have a love for it. You should not take it কি না এটাও সব সাবজেক্টের মতন একটা বরিয়ে আমরা তো গাইনি করবো, আমরা এইসব তো করবোই না। ছেলেরা ভাবছে will become surgeon by some other methods, কেউ কেউ আছে MCH করবে। Well, so those who are going to do MCH, go ahead, do it. So all of them are very important. All of them have important lumps, and they can come up present with big lumps, very big lumps of abdomen, painless lump, and these usually don't move with respiration. They don't move side to side. No, movement is usually not there. Mobility is less, restricted mobility, because they're retroperitoneal. They are very big limbs. They cause pressure symptoms, or a blood vessels er upore thakle they cause pressures, and there will be varicosity on the legs. There will be swellings on the legs. There will be ascites, fluids will collect in the abdominal cavity, and patient will have malaise. এগুলো নর্মাল যেগুলো হয়, ডিসরাপশন, খেতে পাচ্ছে না, ইনডাইজেশন, loss of appetite, feverishness, feeling of feverishness, loss of weight, all this will be there. And if there is metastasis, then only he will end up with obstructive jaundice. He might have, if there is a total failure, all the signs of failures will be there. That's very late stage, because these patients come to us in a এত দেরি করে আসে ততক্ষণে ছড়িয়ে গেছে। বাট বেস্ট পার্ট ইজ এটার মধ্যে ম্যালিগন্যান্সি যেগুলো হয়, দে আর নট মাচ। আমরা বলতে পারি সার্কোমা ভীষণ কমন, ঠিক আছে? তো লিম্ফোমা সার্কোমা, লিওমা সার্কোমা, দিস আর মানে যেগুলো রেট্রোপেরিটোনিয়াল গ্রোথস এর মধ্যেও, তার মধ্যেও কে বেশি কে কম হয় সেটাও উই উইল স্টাডি, ঠিক আছে? তো the best part is they occur rarely, they happen rarely. তার মধ্যেও malignant portions are rare. Not all of the retroperitoneal tumors are malignant, so that is the best part. তাই না কি? Malignancy হয় কিন্তু 1 to 2% only. কিন্তু retroperitoneal tumor mass you have to keep in mind, কারণ ওগুলো abdominal tumors থেকে separate। তো যখনই আমরা পেট দেখছি, এটা মাথা থেকে বেরিয়ে যেন না যায়, যেটা রেট্রোপেরিটোনিয়ালি বোধহয় বড় হচ্ছে, সেটাই হচ্ছে মোস্ট ইম্পর্টেন্ট থিং। এই যে মিসেন্ট্রি, যারা যারা বুঝতে পারিনি তখন, দিস ইজ দ্য মিসেন্ট্রি, তার মধ্যে সব বেরিয়েছে। আমরা সিস্টটা এটার মধ্যেই দেখছিলাম আগেরটা। দিস ইজ রেট্রোপেরিটোনিয়াল স্পেসে অর্গানস, ওকে? পেয়ার্ড ব্রাঞ্চেস কি কি আছে, আনপেয়ার্ড ব্রাঞ্চেস কি কি আছে। ওকে, তুমি পরেরটা দাও। রেট্রোপেরিটোনিয়াল যে মাসলস গুলো আছে, দিস ইজ ইম্পর্টেন্ট। ইলিয়াকাস বলছিলাম না, সাস কোয়াড্রেটাস লাম্বোরাম, নার্ভস। এরপরেরটা এইগুলো কেন ইম্পর্টেন্ট? বিকজ whenever you try to cure a retroperitoneal tumor mass, যদি কোনো অর্গান থেকে না রাইজ করে থাকে, ও নিজের থেকে রাইজ হয়েছে, সারাউন্ডিং অর্গানগুলোকে কেটে বার করে দিতে হয় টু প্রিভেন্ট আ রিকারেন্স। আদারওয়াইজ রিকারেন্স ইজ দ্য মেইন প্রবলেম থিং ফর retroperitoneal tumors. এই জন্য লাইফ স্প্যানটা খুব কম হয়ে যায়, 30% হয়ে যায় যদি আমরা জাস্ট টিউমার মাসটাকে বেরিয়ে চলে আসি। That is the reason you have to know the anatomy well, because whenever you remove the tumor only, you don't treat en bloc dissection kake bole, when the surrounding structures associated or in the surroundings are also removed, tara tokhono affected hoyni, but you have to remove them at least one major organ by the side, otherwise the recurrence will be very fast. আমরা এতদিনে scientists have come to this conclusion. I mean 30 years back when we had studied, and in the process we are still now learning that তখন ছিল just en bloc dissection of the tumor mass was sufficient. We gave chemotherapy, radiotherapy later on, immunotherapy later on, but that is not done now. We tend to stage down the tumor, but we have to diagnose it properly, what type of tumor it is, whether it will respond to immunotherapy or radiotherapy, external beam radiation or internal beam radiation, or what kind of treatment, what is this pleomorphic status, what is the genetic deficiency where P53 tumor marker is involved, whether it is arising from seminoma, teratoma, whether it is a testicular tumor that is dealing. So type, variety has to be assessed before you start the treatment. এই জায়গাটা একটা progress for retroperitoneal tumors from above. We have to know all this because we need to have a good recovery for the patient. ও বারবার করে ভালো হলো না, এত লাখ টাকার অপারেশন তুমি করে বেরিয়ে এলে আর রিকারেন্স আবার থেকে হয়ে গেল, তো ইটস নট দ্য ডান থিং. The thing we are still now, the scientists are still at work to find out what is the best treatment for the patient, because where you are stuck up bad. If you are stuck up, you are stuck up bad. Your patient doesn't recover, he will come back again and again and again. What they have found out, you do an en bloc dissection, not piece by piece. You do a total thing. Vipals তার মধ্যে একটা অপারেশন, যেটা en bloc dissection. Vipals অনেকগুলো অ্যানাস্টোমোসিস করে বেরিয়ে আসে. Vipals alone, teaching you Vipals alone will take me 3 to 4 classes. সেই জন্য whenever an organ, retroperitoneal organ is being taught to you, the tumor associated will be taught alongside. যখন প্যানক্রিয়াস পড়বে তখন প্যানক্রিয়াসের পুরো ভিপলস সব পড়বে, যখন কিডনি পড়বে তখন কিডনি টিউমার্স নিয়ে পুরোটা পড়ে যাবে, যখন ব্লাডার পড়বে ব্লাডারের টিউমার নিয়ে পড়বে. তো আমরা তাও আমি ক্রোমোসাইটোমা আমি ডিসকাস করার ইচ্ছে আছে, আমার ব্রোনস টিউমার ডিসকাস করার ইচ্ছে আছে, রেটিনোব্লাস্টোমা, একটু হজকিন্স ডিসকাস করার ইচ্ছে আছে.